Christina, do you want to pull the slides up? Hello, everyone, and welcome to the Quality Improvement Academy. We are excited to have you join us today. My name is Amanda Wagner, and I am the QI nurse for TCHMB, and I'm going to go over just some quick housekeeping before we dive in. So first, I do want to let you know that this session is being recorded and will be available to view later. And additionally, you all should have received an email this morning with a link to resources. The slides for this presentation are available at that link, as well as many of the tools that we'll be referencing and other resources that we thought might be helpful. Next slide, please. Please feel free to join us on your social media platforms with the hashtag TCHMB 2021. This is the hashtag for the entire conference, so make sure to use it throughout the rest of the week. Next slide, please. We do have some just general IT troubleshooting ideas for you. Just think general things like checking your Wi-Fi, logging off and back on, or restarting your computer. If you're still experiencing difficulties, please contact Zoom support. Next slide. Today, we do have both the Q&A feature and the chat box available. We ask that you direct all of your questions to the Q&A box and reserve the chat box for general discussion. Next slide. We will also be using the chat box to engage with all of you throughout our sessions. Next slide, please. We are offering CE credits for the entire summit. In order to receive them, you must complete an evaluation by February 17th. The link to the evaluation will be in the chat box in just a minute, as well as posted again in the chat box at the end of the afternoon. Additionally, you'll receive an email with that link later this evening, and you can also find it on our website. Next slide. There is a total of 18.75 CE credits being offered by DSHS for this summit. 2.75 of those are for this session this afternoon. Next slide. Again, to receive the credits, you must attend the entire session and complete the survey. Next slide. This event received no commercial support. The following planning committee members and speakers for this event have disclosed financial interests. Nicole Purnell received grants research support from Merck for Mothers. Maha Madarik owns a share and is a co-founder of Embodied Inc. And no other planning committee members or speakers have financial interests to disclose, and neither of those individuals were involved with this particular session. Next slide, please. Joining me today are Dr. Christina Davidson, Dr. Carrie Epps, and Dr. Patrick Ramsey. Dr. Davidson is an associate professor of maternal fetal medicine and the vice chair of quality, patient safety, and equity for the Department of Obstetrics and Gynecology at Baylor College of Medicine. She's the vice chair for the Society for Maternal Fetal Medicine, Patient Safety and Quality Committee, and the Muse advisor for the Texas AIM Initiative. She's currently the co-chair of TCHMB's Obstetrics Committee and has been either the chair or the co-chair of the OB Committee since TCHMB's inception in 2014. Dr. Carrie Epps is an assistant professor of maternal fetal medicine for Baylor College of Medicine and the medical director for the Texas AIM Initiative. She is currently the chair of TCHMB's executive committee and has previously served as the co-chair of both the obstetrics and data committees. And Dr. Patrick Ramsey is a professor and division chair for maternal fetal medicine at UT Health San Antonio. He's currently the chief medical officer for TCHMB, having also served as co-chair of the data committee and the vice chair for the executive committee. Next slide, please. So transitioning from this morning's session on race equity, which was largely discussion geared towards conversations around systemic issues that cause disparate outcomes that we see today. This afternoon, we're going to focus on training in QI basics and how to incorporate health equity strategies into all QI work. We have a lot to cram into the next 3 hours, and we have more than 350 people with us. So our opportunities for Q&A might be limited. Another reminder to direct all of your questions to the Q&A box, and we will do our best to answer them during the workshop. But we will also be available following the workshop from 4 to 5 to continue answering questions for anyone who is able to stay on with us. Additionally, you can email me at awagner@utsystem.edu. Again, that is awagner utsystem.edu. And we will also be sending out a frequently asked questions document after this session with just a lot of the questions that come in that we don't have time to answer. With that, I'm going to hand over to Dr. Christina Davidson to set the stage for us this afternoon with a brief overview of racial and ethnic disparities in maternal infant health. Dr. Davidson?
Thank you so much, Amanda. I just want to confirm, can you hear me?
Yes, I can.
Okay, excellent. And Amanda, you didn't introduce yourself, and so I would just like to introduce Amanda Wagner, who is our quality improvement nurse for the Texas Collaborative for Healthy Mothers and Babies. And really this course, we did it last year for the first time, and it was truly all Amanda's inception. And our goal is to teach basic QI concepts. And last year we infused our maternal early warning system as our framework for it. And this year we wanted to use health equity as our framework for it. And so I'm going to just set the stage with some background to kind of talk through, let me make sure my clicker is advancing. To talk through why are we here today to talk about this, and why is this important, and what is the history that we can work to impact. So I'm going to go through addressing racial and ethnic disparities in maternal and infant health, their root causes and corrective action plans. My goal is to approach this from the standpoint of doing like a root cause analysis. So I'm going to start out by reviewing the literature on racial and ethnic disparities in maternal and infant health, and also in COVID-19, then analyze the root causes for these disparities, and then attempt to outline a corrective action plan to achieve health equity. And we will spend the rest of this afternoon going through in more detail what we can do with that corrective action plan. As we go through this session, some terms will emerge that I'll define as we get to them, and you can bucket them into these 4 buckets. One being disparity and equity, another one being bias, another bucket is racism, and another bucket is social determinants of health. According to the CDC, about 700 women die each year in the United States as a result of pregnancy or its complications. American Indian and Alaska Native and Black women are more likely to die from a pregnancy-related cause as compared to white women. In fact, Black women are 3 to 4 times more likely to die of pregnancy-related death as compared with white women. And this is independent of education, income, and comorbidities. On this bottom slide, you can see the comparison of maternal death as compared to your level of education. And when looking at level of education, for Black women with at least a college degree, there's actually a 5 times higher rate compared to white women of maternal death with a similar education. Black women with graduate degrees have higher rates of severe maternal morbidity than non-Hispanic white women who never graduated from high school. And this is the most recent data we have, which is from 2018, that shows a maternal death rate of 17.4 deaths per 100,000 live births. And we continue to see racial and ethnic disparities, with the maternal death rate being approximately 37 for non-Hispanic Black women. And this is compared to almost 15 for non-Hispanic white women and close to 12 for Hispanic women. And when looking in Texas, we see a similar trend that we see nationally. So in this graph on the left, you can see the maternal mortality rate for Texas compared to the United States, with Texas being the orange graph on the top. And we can see that the maternal mortality rate in Texas has been often higher than the rest of the United States. And looking on the right graph, we see maternal mortality rates by racial and ethnic group. And this orange line on the top shows the Black women, which you can see is much higher than the mortality for white or Hispanic women, or compared to the rate of Texas. And when looking at infant mortality, we also see that it varies by race. When you look at it for the 2017 to 2018 years, infants of non-Hispanic Black women had the highest mortality rate, and that was followed by infants of non-Hispanic Native Hawaiian or other Pacific Islander, non-Hispanic American Indian or Alaska Native, Hispanic, and finally, non-Hispanic white and non-Hispanic Asian women had the lowest rates. Additionally, a recent publication examining 1.8 million hospital births in the state of Florida between 1992 and 2015 suggests that newborn physician racial concordance is associated with a significant improvement in mortality for Black infants. The study demonstrated that under the care of white physicians, Black newborns experienced triple the in-hospital mortality rate as compared to white infants. Black women also are at a higher risk for death from certain conditions as compared to white women. When you look at the epidemiology of this, we see that Black women have higher mortality from cardiomyopathy, hypertensive disorders of pregnancy, and hemorrhage, with them being almost 10 times more likely to die with a diagnosis of pregnancy induced hypertension, and almost 5 times more likely to die with a diagnosis of hemorrhage. And deaths in Black women are more likely to be considered preventable when reviewed by statewide maternal morbidity and mortality review committees. In addition, Hispanic women have increased risks of death due to hypertensive disorders. So we talk about mortality a lot, but when we think about mortality, we know that really it's the tip of the iceberg. And for every maternal death, there are at least 100 cases of severe maternal morbidity, which are all of those events that can lead up to the maternal death. Severe maternal morbidity as a general concept is the unintended outcomes of the process of labor and delivery that result in significant short-term or long-term consequences to a woman's health. And then you can also identify these by the CDC through ICD-10 codes. There's a list of 21 conditions that are considered severe maternal morbidity by the CDC that you can see here on this slide. And again, all of these events are steps in the pathway leading up to maternal mortality. And so these are also opportunities to intervene and prevent the mortality, and then hopefully intervene to the point of even avoiding the morbidity. And this table just shows, I know it's difficult to see, but the point of putting this in here is to show that Black women have more than a twofold greater risk of severe maternal morbidity compared to white women. And when you look at this table, which lists out each severe maternal morbidity code individually, you can see down the list that each one of them says that it's increased among African American women and often increased among Hispanic women as well. And once again, we see that the same pattern is mirrored in Texas, where we see that the severe maternal morbidity in Texas, the most common cause in 2014 was hemorrhage, which is why the state implemented the OB hemorrhage bundle over the last couple of years. And again, when you look at this graph on the right side, you see that Black women who are represented in that top orange line have a much higher morbidity related to hemorrhage as compared to women of other races and ethnicities in the state. And this data was also supported with more recent reviews of this information. Looking at COVID-19, we see nationwide there's a disparate outcome in regards to hospitalizations and deaths. Compared to non-Hispanic white persons, hospitalization rates are almost 3.6 times higher among non-Hispanic Alaskan, American Indian, American Indian or Alaska Native persons, and it is almost 3.2 times higher among Hispanic or the Latinx population, and almost 3 times higher among non-Hispanic Black persons. And when you look at deaths, what they were showing even early on in the pandemic is that counties that were majority Black had a 3 times rate of infections and about a 6 times rate of deaths as compared to majority white counties. And when you looked at cities or even states where you were looking at the death rates, you could see, for example, that in Chicago, more than 50% of the COVID-19 cases and about 70% of the COVID-19 deaths involved Blacks. However, the Black population was only about 30% of the total population in Chicago. And we saw similar trends in Louisiana and Michigan. So now we've kind of reviewed the data and we get to having identified our problem for this root cause analysis. The problem is health disparities, and health disparities are differences between the health of one population and another in measures of who gets disease, who dies from disease, and other adverse health conditions that exist among specific population groups in the United States. So what we know is that Black women are 3 to 4 times more likely to die from a pregnancy-related cause and have more than twofold greater risk of severe maternal morbidity as compared to white women. Black newborns are more than twice as likely to die in their first year as compared to white newborns. There's a disproportionate rate of COVID-19 infections, severe morbidity, and mortality in communities of color, and most morbidity and mortality has been found to be preventable, especially in Black women. So now we're going to try to get at why is this the case? And again, we're going to approach this from a root cause analysis. So what is a root cause analysis, or an RCA? It is a structured method used to analyze serious adverse events. And it's a process for identifying the basic or causal factors that underlie variation in performance. It focuses primarily on systems and processes and not on individual performance. So there may be multiple root causes of a problem because different people who see different parts of the system may answer the questions differently. So a few months into the pandemic, this was published back in May of 2020, actually, in OB-GYN News. And it really struck me because we were seeing on the news the disproportionate outcomes in the Black and Latinx population from COVID. And I wasn't really surprised to see this because of everything we know happening with maternal and newborn morbidity and mortality. And so this is an article that quoted Dr. Gee, who is the director of the Louisiana State Health System. And she said in an interview, it's kind of surprising to me that people are shocked by these COVID-19 disparities. I mean, if you're not shocked by 4 or 5 Black women dying for every white woman that dies in childbirth, I don't know what would wake you up. If this is it, great. And certainly every moment is a moment for learning. But these COVID-19 disparities should not be surprising to people who have been looking at the data. And then Dr. Gillespie, who's the medical director of the Louisiana Perinatal Quality Collaborative and the Pregnancy Associated Mortality Review Committee, went on to say, now there's a task force and all these initiatives to look at why this is happening. And I think those of us who work in mortality, in maternal mortality, are all saying, we know why it's happening. It's the same thing we've been telling people why it's been happening in maternal mortality. It's implicit bias and structural racism. So, what exactly is race? Well, race is a social, not a biologic construct for grouping people together based on skin color and other apparent physical differences. Racism is a system of advantage based on race, and it can be classified as internalized, which is the set of private beliefs, prejudices, and ideas that individuals have about the superiority of whites and the inferiority of people of color. It can also be classified as interpersonal, which is the expression of racism between individuals. And this can often take place in the form of harassment, racial slurs, or telling of racial jokes. Institutional or structural or systemic racism is discriminatory treatment, unfair policies and practices, and inequitable opportunities and impacts within organizations and institutions that are based solely on race. And in a joint statement that ACOG just published over the summer with many other organizations, they stated that recognizing that race is a social construct, not biologically based, is important to understanding that racism, not race, impacts healthcare, health, and health outcomes. And this quote on the side of the screen really struck me when I came across it. I borrow it from Dr. Joya Creer Perry, who is the founder and president of the National Birth Equity Collaborative. But I think it's very important as we approach everything that we're about to talk about today is to recognize that race is not a risk factor. Racism is. This is a model demonstrating pathways to racial and ethnic disparities and severe maternal morbidity and mortality. And it highlights that the drivers of healthcare disparities exist at 3 main levels: the patient, the provider, and the system. Patient level factors include the perceptions of the quality of care received, the quality of the relationship with the healthcare provider, and perceptions of health and illness from a sociocultural context. Provider factors include the knowledge and attitudes of physicians, nurses, social workers, and other healthcare providers. And there's growing emphasis on the improvement of cultural humility among providers, the establishment of effective interpersonal and working relationships with patients by recognizing the social and cultural influences that are important to them. And system level factors that contributed to disparities include healthcare systems and services, access to and use of healthcare, and the quality of care that is actually delivered. A key patient factor to consider is one's social determinants of health. Social determinants of health are the conditions in the environment in which people are born, live, work, and age, and they're shaped by historical, social, political, and economic forces and help explain the relationship between environmental conditions and individual health. So when you combine social determinants of health with inequities in access to healthcare and potential for language disparities and distrust of the healthcare system, all of that can lead to disparate outcomes. So why is there fear and mistrust of the healthcare institutions? Well, for the Black population, this goes all the way back to slavery, a time when experimental reproductive surgeries, such as cesarean deliveries and vesicovaginal fistula repairs, were commonly tested on enslaved Black women without anesthesia. And then when you move beyond slavery into the Black codes and Jim Crow era, there was coerced sterilization, where programs coerced African American women to undergo sterilizations without their full knowledge that these procedures were not reversible. Additionally, unnecessary hysterectomies were performed at teaching hospitals as practice for medical students. And then even getting into the civil rights era, there's an infamous study, the Tuskegee study of untreated syphilis in the Negro male, which began as a study to record the natural history of syphilis. It was originally projected to last 6 months. However, the study actually went on for over 40 years. The men were never given adequate treatment for their disease, even when penicillin became the drug of choice for syphilis in 1947. And this study did not conclude until 1972 when the word got out to the public and there was a public outcry about it. And so, just to put that in context, I was born in 1973. So, this is still a very fresh in the memories of many of us who are still alive today. And so this also lends towards why there's a reluctance in the Black community to even get the COVID vaccine right now because of this mistrust in research and the healthcare institutions. And then legal healthcare segregation or healthcare segregation remained legal into the mid 1960s. In fact, I actually was just talking to my mom before this talk. It's a story that I had remembered from a long time ago, but I was just thinking about it as I was preparing for the talk and asked her for the details again. My mom is 77 years old, and she was born in Galveston at John Sealy Hospital, the hospital where my husband did his medical training. And when she was a child, about 5 years old, she needed to have her tonsils removed, but the Black ward of the hospital was full. And so she was sent home and put on a wait list, and it would be another year before she went on to get her tonsils removed. And my mom, as a result, they think of that as why she has rheumatic heart fever. And then, even leading into the post civil rights movement, hospitals and clinics once reserved for minority families remain under resourced, and Black women are more likely advised to restrict childbearing and undergo hysterectomies for conditions that are potentially treatable by less aggressive procedures. And when we think of the Hispanic population, we know that there is often a fear of immigration enforcement or language barriers that prevent them from seeking care. This is something that I just recently came across in some information research that I was doing in a webinar that I saw from the Institute for Perinatal Quality Improvement. And they actually created this maze of life. So, and they created it to help illustrate the fact that the starting point and the path for Black pregnant women is a more difficult path with more twists and turns and more obstacles than the path that most white pregnant women embark on in order to achieve health equity and prosperity. As you can see here, the Black woman is weighed down with a backpack that says 246 years of slavery and also the fear of dying. And at the start of her path are Jim Crow laws, racist policies, unequal human rights, legalized rape, disproportionate incarceration in the context of lynching of loved ones or fear of lynching, which then led into families being separated, high rates of infant mortality, redlining, police violence, disparities in educational resources, unsafe water, limited access to quality health care, and other dead ends that all make it more likely that a Black woman will experience morbidity and mortality when giving birth in the United States. The maze shows that Black women can achieve health equity and prosperity, but the path to health and prosperity is much longer and much more difficult to navigate. The maze also shows that a white woman can experience maternal morbidity and mortality, but it is much less likely that she will. And then when we think about system factors that contribute to this disparities in care, we can look at delivery hospital quality and access to care. Studies have demonstrated that Black patients tend to receive care in hospitals with higher mortality rates and lower rates of effective evidence-based medical treatments compared with white patients. These studies suggest that place matters, and there's growing attention to improving quality of care during delivery hospitalization to reduce disparities in maternal mortality and morbidity. It's also important to note that racial and ethnic disparities have been documented both between hospitals and within hospitals, and improvements in quality of care may address both of these causes of disparities. Hospitals that disproportionately care for Black deliveries have been shown to have higher risk adjusted severe maternal morbidity rates for both Black and white women in those hospitals. And this is thought to be because these are hospitals that are in areas that were under resourced, where there was legal healthcare segregation, and they still to this day don't have the resources that other hospitals have. And then when compared to whites, Hispanics and Blacks are also much more likely to be uninsured and not seek medical care because of inability to get off from work or not having the money for it. And then moving on to potential provider factors, even when minorities seek healthcare, there's a risk that implicit bias can hinder the care that they receive. Implicit or unconscious bias is a mechanism of unconscious discrimination, and it's a form of racial or other bias that operates beneath the level of consciousness. So it's when you see things and are exposed to things over your life, and everybody has some kind of implicit bias. It doesn't make you a bad person, it's just a result of what you've been exposed to in your life. But those exposures can generate stereotypes that can then lead to automatic associations or attitudes about a race or a gender, so that when you go into care for a patient, you may trigger that upon entry unconsciously, not even realizing it. That leads to a prejudging and a change in your behavior, which then ultimately can lead to discriminatory care. In a 2015 survey done by the Society for Maternal Fetal Medicine, 83% of respondents agreed that disparities have an impact on their practice. However, only 29% believe that personal biases affect how they care for patients. So, hence the term unconscious. And these stereotyping and implicit biases are most often, they're most enhanced in situations marked by ambiguity, stress, and time constraints, which I feel like is a basic definition of obstetrics and neonatal and infant care. And in the prenatal setting, Black women have reported perceptions that their provider made negative stereotypical assumptions about their status regarding insurance, marriage, and substance abuse, resulting in unfair treatment. So, what can we do about it? Well, that is what we are all here to talk about. And one thing that we can do is use quality improvement to address health equity. And I'll also address a few other things. The good thing is that achieving health equity has alignment. And there are a lot of organizations talking about this. There is so much more information that I've come across in just even the last couple years. But we have an AIM bundle on reduction of peripartum racial and ethnic disparities. ACOG has publications, and the Institute for Healthcare Improvement also has a guide for healthcare organizations to achieve health equity. One of my favorite things that I like to use for these talks is this infographic that was put out by the Society for Maternal Fetal Medicine early in the pandemic on strategies to provide equitable care during COVID-19. And I borrow their illustrations to show what the difference is between equality versus equity. And if anybody, I know that many of you were in the morning session on race equity training, and Joyce James went through just a beautiful description of this in terms of what the difference is between equality and equity. And when I use this picture, I think a lot about these step stools representing step stools in the operating room. So just to describe the difference, equality is when you give everyone the same thing, and equity is when everyone has the opportunity to attain their full health potential, regardless of where they're starting. So in this top picture, you see that there are three different individuals standing on a hill and they're looking over a fence, and they're each given a step stool to see over that fence, but they have different views because of where they're starting on that hill. And so in the bottom picture with equity, each person is actually given the amount of step stools they need to be able to see over that fence. And so I think of this as being in the operating room doing a C-section with one of my residents. And I'm about 5'2". And so if I'm operating with a resident who's just a little bit taller than me, I usually ask for one step stool so that I've got enough height to provide appropriate fundal pressure and retract and expose well enough for them. But if I'm operating with a really tall resident, I've had to ask for two step stools before so that I can do that same thing, so that I can provide the same care to the patient, but I'm starting out at a different point because the differential in the heights is different. And then Joyce even showed a picture where the fence was just completely blown down. And that's when you just have completely eliminated the barriers that you're dealing with in the first place. And a quote that I've heard a lot in race equity and quality improvement talks that I've been to is that there is no quality without equity. So we really need to think about this bottom picture as we approach everything. And what does each person need or each group need to achieve their full health potential? And one of the ways that we can approach this is through the AIM bundle on reduction of peripartum racial and ethnic disparities, which, just like all of the other bundles, separates components into the 4 Rs of readiness, recognition, response, and reporting and systems learning. However, instead of thinking of this as a standalone bundle, this bundle can actually be incorporated into every single bundle that AIM has. And in fact, they are currently working on doing that and incorporating this as a 5th R to every single bundle. But here where I could have put a red arrow next to every single bullet point truly, because they're all so important. But I just highlight a few of the things that we'll spend the afternoon talking about. One is the importance of having self-identified race, ethnicity, and primary language in your readiness, because that leads you into your reporting, where you can develop disparities dashboards to monitor process and outcomes metrics. Also, there's a focus on staff-wide education regarding peripartum racial and ethnic disparities and their root causes and on implicit bias. And then also engaging in best practices for shared decision making. So being more engaged with our patients to have that shared decision making and making sure they have the information that they need to help engage in those conversations. So let's talk first about some patient factors. And we talked about the social determinants of health, which include food, utility, housing, childcare. However, when screening for them, it's also important to have a plan for what to do when needs are identified. And I know it can seem very overwhelming. You're in a busy clinic and you're going to go and talk to patients, and how are you possibly going to help with their housing needs? But sometimes the things that you may find are actually a lot easier to address than you may realize. One important thing is to include a social worker or a community health worker in your practice, but sometimes it's just asking the questions. I have learned so much from my patients over the years about social determinants of health long before I even knew of this terminology. And what I have learned is that our patients in general are not non-compliant. They are experiencing barriers to compliance. And I just actually had this interaction yesterday when I was staffing our MFM clinic at our safety net hospital. I noticed a patient hadn't been seen in person since December 28th, actually. So it'd been about 6 weeks since our last in person visit. We were seeing her in the clinic because she has type 2 diabetes and she's on insulin. But I saw that she'd had some telephone encounters with one of our certified diabetic educators. And it was really detailed. She had all of her sugars in there and she was taking her insulin. So when I went in to talk to her, I asked her, I said, I noticed you haven't been able to come to your in person visits in a little while, but you've been doing your telephone visits. Is there anything in particular going on that's making it difficult to come in person that we could help with? And what she said to me was, my kids are doing school from home right now. And I'm afraid that if I'm not home and paying attention and overseeing what they're doing, they're not going to pay attention to school. So it's really hard for me to get here on days when they're in school. And I said, that makes a lot of sense. I can completely understand that. Are there any days or times that work best for you? And she said, yes, actually, Tuesday, right in the middle of the day, works really well for me. Happened to be the exact same time we were having this clinic visit yesterday. So we made a note that all of her appointments needed to be on Tuesday in the early afternoon. And it was just that simple conversation with her instead of labeling her non-compliant for missing all of her visits. And another thing that is important to do is make the implicit explicit in the exam room and pursue equity in the exam room with your patient. These are some tips from a hospital that participated in the Pursuing Equity initiative with IHI. And what they talked about was it's important to create a safe and welcoming environment for your patients that celebrates and acknowledges their identity and culture. For example, having a pride flag or a Black Lives Matter poster, or posters in the preferred language of patients, posters stating that people of all documentation statuses, races, and gender identities and religions are welcome. And ask better questions. Ask about experiences in the healthcare system. Ask about life experience. Ask relevant follow up questions and make sure they feel heard and incorporate what they're saying into your care plan. Have and ask relevant questions so that you can make sure you are able to incorporate it into their care plan. And then listen to understand and not just to respond. Effective patient provider communication is paramount to delivering high quality health services. And patients are a lot more likely to share information helpful to their provider when they feel that they're being valued. We also need to give our patients the information and the power through education to be able to explain to us and identify and recognize themselves when they're having signs or symptoms that require urgent attention. So here on the left of the screen is actually something that was done jointly through the CDC and the Council for Patient Safety on Women's Health, which is urgent maternal warning signs. It's like the patient version of maternal early warning signs that we do in the hospital. And this lets the patient know what kinds of things are they experiencing that should bring them back to the hospital. It's in other languages in addition to English. And on the right of the screen, you see this from the Hear Her campaign with the CDC. It's actually a guide to help start the conversation. So the patient knows how to express this information to her provider. But it's important for us to engage in those conversations and not dismiss their concerns, which is part of the implicit bias that often can lead to poor outcomes in our patients. Going into provider factors, we need to consider ourselves lifelong learners. Just as we read the medical literature when new studies come out and we alter our medical practices, This training in addressing racism and implicit bias is now getting put into nursing and medical student education. But for those of us who've been in practice, I finished residency 20 years ago. For those of us who've been in practice for a long time, we did not get this. And now we may be in a situation where we need to be the learner so that we can learn how to teach this information and have almost like a train the trainer type of system. And so Family Medicine published on this, where they had racism faculty development workshops where faculty members engaged as learners, and they felt that at the end of it, there was an improved confidence in teaching learners to reduce racism in patient care. And then there was a parallel implicit bias training for both residents and faculty, where they both agreed that they had new practices to address racial bias. It is important to go about this in a very systematic and structured way. Implicit bias training is not going online by yourself and doing the implicit association test and then feeling like a horrible person because you don't know how to process that information or what to do with it, because we all have a bias of some sort. It is important to identify that bias and then go through some type of training experience with colleagues or in a group setting where you can talk through the different scenarios and how you can actually use strategies to mitigate the impact of those implicit biases. And this is just an example of what was used in the family medicine training, where they had two sessions that were led by experts. And the first session talked about race, racism, whiteness, and implicit bias. But then the second session were group discussions of barriers to addressing the bias and tools of how to address it. And I've seen this in two different talks that I've been in, that I participated in over the last week, where this is a recent post on social media. I cut off the face just in the interest of, because I'm taking this straight off of the internet. But it really, I thought, again, another thing that really spoke to me, where this gentleman is holding the sign that says Black Lives Matter, and says to, something that we can all think about as we're approaching learning and teaching this information: treat racism like COVID-19. Assume you have it, listen to experts about it, don't spread it, and be willing to change your life to end it. And then moving on to system factors, the most important factor in preventable morbidity and mortality is actually improved quality of care. And quality initiatives aimed at standardizing delivery will improve care at all hospitals, and including the lowest performing hospitals, which unfortunately, as I mentioned, serve a disproportionate number of racial and ethnic minority women. So this can be done through things like safety bundles, protocols, checklists, triggers such as the maternal early warning criteria, simulation trainings, team and staff training, care coordination and crew resource management, and promotion of a safety culture. And then data. We're going to hear a lot about data as we go on, and you'll see this slide again, but you can use your data to figure out where disparities may exist. I know when I first embarked on this journey a couple of years ago of trying to look at the data in a way that would be meaningful, I thought, well, I need to create some completely new metric to figure out if I have disparities in my hospital. And that's not actually the case. You can take any data metric that you are already looking at, any quality metric, and just stratify it by race and ethnicity and language, and just use the model for improvement, the IHA model for improvement with the Plan, Do, Study, Act, where you think about the first point. What are we trying to accomplish? If you provide organizational leaders with strategic measures stratified by race, ethnicity, and language that reveal disparities, then you can do target interventions to reduce or eliminate them to improve care. And how are you going to know that a change is an improvement? Well, the stratified data helps organizations identify these inequities so that you can inform action and improve overall performance. And what change that will you make that will result in an improvement? Again, you can just identify one strategic measure that the organization wants to improve. We did this at my hospital with severe maternal morbidity and morbidity from hemorrhage as we were going through the hemorrhage bundle. And then you can provide the stratified data for that measure to identify opportunities for improvement. And you can use any type of quality measure, or all of them for that matter, whether it's access, it's structure, process, patient experience, or outcome. All of these data metrics can be stratified by race and ethnicity and language. And does it make a difference? Well, California has taught us so much about quality improvement. And once again, they do show that quality improvement work can make a difference in racial and ethnic disparities in healthcare. In this study of 99 California hospitals that participated in the OB Hemorrhage QI Collaborative, they showed that pre-intervention intervention, the highest rate of severe maternal morbidity was in Black women and the lowest rate was in white women. However, after the intervention, the morbidity rates reduced for all races, but the benefit among Black women exceeded that of white women. And the authors concluded that improving access to highly effective treatments has the potential to decrease disparities for care-sensitive, acute hospital-focused morbidities. These clinical efforts should be in parallel, however, with efforts to reverse bias and racism in the medical system by treating Black women with respect and dignity, better understanding their circumstances, and listening to and acting on their concerns. And ACOG also has published some things that we can listen to and consider. In the interest of time, I'm not going to read through all of them, but you will have access to these slides. And I just want to conclude with a quote from Dr. Martin Luther King Jr., who says, "Of all the forms of inequality, injustice in healthcare is the most shocking and inhuman." Thank you all for your attention. I'm going to stop sharing now and turn it back over to Amanda.
All right, everyone, give me just a second to get the slides back up. All right, so now we're going to transition to the more training-centric portion of the workshop. I'm going to quickly discuss some key concepts and principles, compare some QI strategies, describe some tools, and incorporate health equity throughout. I also want to start with a quote. "The pursuit of safety is not so much about preventing isolated failures, either human or technical, as about making the system as robust as is practicable in the face of its human and operational hazards." So the point here is that we're not trying to make perfect systems. We're trying to make them as best as they can be, understanding that humans make errors and that's okay. We're just trying to reduce them as much as possible. So a few key principles of QI. First, it focuses on systems and processes, not on individuals. It focuses on the team as a whole. It uses data to drive it, and it focuses on the patient and the family. That's what it's all about, improving the outcomes for the patient and the family. The QI culture requires leadership commitment and involvement. So this isn't, a once a year seminar where they say we need to be working on quality improvement and then the senior leadership steps out. It's an ongoing conversation with them all the way through every project that you're doing, letting them know why you need to do it and how it's going. Again, it's based on teamwork and collaboration. Very important that it's multidisciplinary, driven by patient safety, and then again relies on data, and that data should be stratified by race, ethnicity, and language. The health equity culture, very similar, but it has a few key differences. It includes health equity in the organization's mission statement and designates a leader to champion the disparities reduction. It also measures the cost of health disparities, and that's largely done within the organization, but it should also include costs external to the organization at the larger level of health system available within a particular region. It empowers employees to implement focused interventions. And then it also provides training in cultural competence. And I would also add implicit bias training there. So the health equity QI process is systematic. So it is guided by methods and tools. It's not just guessing, but there are actual processes that we follow when we're doing quality improvement. It is cyclical and continual. It is not a linear process. It is based on feedback regarding what's going well and what's not going well. And you just keep going back at it and back at it and back at it. And that incorporates change theory and management. And so I want to talk about change theory for just a minute. First, why do we need to implement changes according to a change theory? Well, humans in general are very resistant to change, and we tend to lack commitment to change because change is hard. And therefore, the need for change is often reactive, and that causes it to be unpredictable and discontinuous, which makes the process even more uncomfortable. And because of all of this, that makes it very difficult to implement a lasting change. So now I'm going to ask a few questions about the change process. We're going to take about 10 to 15 seconds per question, and I want you to go ahead and enter your answers into the chat box. I know many of you already have the slides and have the answers already, but I want to encourage you to not look at those right now and just answer based on what you think. So go ahead. How long do you think it takes for new evidence to be incorporated into practice? Saying 2 years, 5 years, 10 years. I'm seeing a couple people have gotten it right. It takes 17 years to implement new change into practice. That's a really long time. Okay, next question. What percentage of new evidence actually makes it into practice? 25, 40, 5, 10, 20, 25, pretty close with these. The answer is 30%. Only 30% of new evidence that comes out of research ever actually makes it implemented into practice. So how long does it take to implement a change? Seeing anywhere from 1 to 5 years being the most common. It actually takes 18 to 24 months to implement a change. And then our last question, how long does it take to root that change into practice? Five years, 4 years, 2 or more years. Okay, so this one might be the most surprising. It takes 10 years to implement a new change into practice, have it rooted in your new practice. Okay, so let's talk about change theories. That all sets the stage for why we need to use an actual theory to implement a change. So change theory started in the 1940s with Lewin's change theory, and it was very basic. Talked about unfreezing the way things are currently done, implementing a new change, and then refreezing that new change into the way things are now done. In the 1960s, Rogers' diffusion of innovation took it one step further, and he laid out the pattern in which people tend to adopt a new change. And it's laid out on a bell curve with the very front end being your early adopters and your innovators. And then the majority of people kind of follow along. And then at the very end, you have your laggards who are just very slow to implement a new change. And then in the 1980s, Prochaska's trans-theoretical model came out that actually applied kind of steps to that process. And so there are plenty of change models today. This is just a list of a few of the ones that you'll see in healthcare. They all contain, they're all similar and contain the same key steps, but they kind of define them each and or lay them out differently. Cotter's 8 steps of change is one of the most commonly used in healthcare, and Dr. Epps is going to go through this in detail later this afternoon, so I'm not going to go through it now. But I also wanted to show you Galpin's human side of change, because this, while the steps are very similar to Cotter's 8 steps, this also has the timeline attached. And you can see there, if you add up all those times around the circle on the right, you get at least a year to 18 months for implementation. And I just think that's really important to set the expectations for how long it's going to take you to do each project. Some key takeaways about change models. There's no right, best theory or model. It's specific to the unit or the department. It's not specific to a change, but to the people making the change. So it's chosen based on what makes the most sense for your team, and then it doesn't change project to project. It's a step-by-step guide for implementing projects. So now we have QI strategies, and these are ways to organize your planning process. Most people have probably heard of some or all of these. I'm going to give more detail on the model for improvement and map it in just a minute. But Lean and Six Sigma have been around for a long time. Lean was developed by Toyota, and its goal is to identify and eliminate waste, and also focus on value according to the customer and to the value streams. And then Six Sigma was developed by Motorola, and it was built on total quality management. And the goal of Six Sigma is actually to become highly reliable by enforcing consistency and reducing variation. The DMAC is one of the common processes used in Six Sigma, which is define, measure, analyze, improve, and control. But I'm going to talk more about the model for improvement and map it. Model for improvement is one of the most popular models currently used in QI work. It's promoted by the IHI, and it's linked with the PDSA cycles and very simple to follow. It starts with 3 fundamental questions. What are we trying to accomplish? How will we know that a change is an improvement? And what changes can we make that will result in improvement? So it uses data to make decisions and focuses on testing and adapting changes, as opposed to drawing up like the perfect policy and then going wide with full implementation across the entire department. So therefore it encourages an iterative process. Again, QI work is cyclical, not linear. MAP-IT is from the Institute for Perinatal Quality Improvement, and it's pretty similar to the model for improvement, but it also recognizes that the team may change over time, and it also draws your attention back to your aim in every cycle. I mean, on the link that has the resources that we sent out and that has been put in the chat a few times, there is a MAP-IT worksheet that you can use to walk through the process step by step. Okay, I also wanted to talk about the Institute for Healthcare Improvement's Health Equity Framework. There are 5 core elements to the framework, and I'm going to go over 4 of them briefly here in a minute. The 5th is related to partnering with the community and is largely outside the scope of this workshop. However, there are detailed guides on all 5 of the elements on the IHI's website. The IHI also has their Improving Health Equity Assessment tool that's available on their website. And that tool helps hospitals evaluate their current health equity efforts to identify areas for improvement. It's to be completed by senior leadership responsible for health equity within the organization. And they each complete it individually, and then they meet to compare and discuss. At that point, they identify goals and incorporate them into their strategic plan for the organization. And then each department aligns their goals with the organization's strategic plan. So the first component is making health equity a strategic priority. And this is done by building will to improve health equity, including equity in the strategic plan and the departmental goals, and demonstrating senior leadership commitment to improving health equity. The second component is to build infrastructure to support health equity. And the biggest part of this is the data infrastructure. You can't address what you aren't measuring. This will be discussed more in the next session with Dr. Ramsey, but I just wanted to address it here briefly. In addition to that, you need to build organizational capacity to support efforts to improve health equity, which includes creating infrastructure for health equity responsibility. So that can either be its own team that's separate, that's all they do in the organization, or it can be that all of the senior leaders throughout the organization share responsibility. And then also educating staff through training on equity and training in equity and opportunities to build knowledge, such as attending this course or the summit this week. So another quote that I thought was really powerful from the IOM Standardization for Healthcare Quality Improvement Report really highlights the need for data infrastructure to support health equity. It says, although the collection of race, ethnicity, and language data does not necessarily result in actions that will reduce disparities and improve care, the absence of the data guarantees that none of that will occur. So again, you can't address what you don't measure. Dr. Ramsey is going to talk more about real data in the next part of this course, but a few quick highlights about collecting data to improve health equity. First, real data is not real as opposed to fake, but it is an acronym for race, ethnicity, and language. It's important to ensure that the same categories for each are being used throughout the organization and that this information is collected from all patients. It must be self-reported and not assigned based on assumptions. And there are several toolkits available to use for creating the infrastructure to collect this information, but most of them recommend using a script to ask for this information and explain why it's being collected and how it will be used. Some of the toolkits specify to ask for the information orally. Others allow for it to be asked on a form, but it's important to consider the patient's language and literacy status before assuming they can complete a form. And it's important to allow patients to select more than one for each category. And then lastly, you might consider adding a question to follow-up surveys to assess how this information was collected in order to check for compliance with the process. And here's just a brief example of what that script might look like. For ethnicity, you might say, do you consider yourself Hispanic or Latino? For race, which category or categories best describe your race? And for language, what is your preferred language for us to use when communicating with you about your healthcare? Okay, so the third component of the IHI's health equity framework is to address multiple determinants of health. This includes reducing inequities in clinical care by stratifying data and then customizing QI efforts according to the results. And you'll hear more about both of those later on. Additionally, it involves screening for social determinants of health and ensuring effective access to social services, and then also improving health equity efforts both throughout the system and beyond. And so this graphic shows many of the social determinants of health that impact the health disparities seen with COVID outcomes. These types of things likely apply to most perinatal outcomes as well. It is not expected that at the unit level, you'll be able to address some of these larger issues, such as access to transportation or grocery stores, but they're important things to screen for and consider, especially when providing outpatient plan of care or discharge instructions. And I think Dr. Davidson gave a great example of this just before with her patient who was missing her inpatient visits due to not being able to leave the house because her children were doing school from home. Those conversations are so important to have at the unit level to really understand your patient holistically. However, at the organizational level, the organization as a whole should participate in these public health discussions in their region to try and improve those larger scale systems. Okay, the fourth component that I'm going to discuss is to eliminate racism and other forms of oppression. And for those of you that attended this morning's session, that was right in line with this component. It includes understanding the historical context for systemic racism, addressing institutional racism and its impact through your culture and communication, establishing policies and practices to promote workforce diversity and racial equity, implementing business policies and practices that promote racial equity, and improving clinical processes and outcomes to narrow equity gaps. And so I think that is a key thing to consider. And I want to highlight why it's so important to incorporate a health equity lens into all of your QI work, because one of three things can happen with a disparity, even if the overall outcome is improved. The first is that disparity increases even more. The second is that the disparity stays the same and both improve by the same amount. And the third is the disparity is decreased. And unless you're specifically watching for this, you won't see it. All you'd see is that your overall outcome is improving. Okay, so I want to jump back to the first question of the model for improvement. What are we trying to accomplish? That is your SMART aim. The first question of the model for improvement is addressed with your SMART aim, and that is your overall goal, but it's important to make sure it's specific, measurable, achievable, relevant, and time specific. So I have an example of an aim, and that is to collect patient-reported data by June of 2021. So go ahead and drop a quick yes or no in the chat box if you think this is a SMART aim or you don't think it is. Okay, seeing lots of no's and a couple yeses. So this wouldn't be considered a SMART aim because one, it's not very specific, and two, it's not measurable. It is achievable, and it is definitely relevant, and it does have a timeline prescribed to it, but it's not super specific and it's not measurable. So one way we might improve this to make a better aim is to say we want to collect patient-reported race, ethnicity, and language data for 100% of patients admitted to labor and delivery by July 1st, 2020. This has become a lot more specific. We've specifically said what kinds of data we mean when we say collect patient-reported data. We've said how many we want, 100%, and that makes it measurable. We can now measure if we're at 100% or not. And then where, we've said which patients are we talking about, and we've made the timeline more specific. Okay, so now that you have an aim, what types of tools might be helpful for your project? This is just a small snapshot of the QI tools that are available to you, but these are some of the most commonly used. For the sake of time, I'm not going to go into detail on all of these, but feel free to email me if you want to learn more about any that I don't cover. I'm going to cover them by general categories. So the first category is process mapping. There are several tools you can use to do process mapping, but basically that just makes the activities of a process or a system visible. So I'm going to cover a flow chart in detail. And this is an example that we created for how you might collect your patient reported data. So the patient arrives, the admitting staff enters the room, and the first thing they figure out is if the patient speaks English or not. If yes, then they go to if the patient is literate and able to read the forms. If yes, then they give them the form and complete their info, and it ends with they enter the info into the EHR. If the patient didn't speak English, instead of following down to yes, we would move over to no, and we would bring in translation services. And then we would jump down to the next question. Is the patient literate? If the answer there is no, then we're verbally asking for that information using a script, and again, ending with entering that info into the EHR. So a flow chart engages all of the people in the process to create one. So if you're trying to map out this process for your own unit, you would definitely want to involve admitting staff on the team to create this chart, because they are one of the most important participants in the process. Then you want to identify all of the steps in a process and arrange them sequentially, and then connect them with arrows showing the process flow. And then you want to validate it with others involved in the process. So then take it out to a larger group and see if everyone else agrees that, yeah, that's what the process looks like. A few key things when you're creating one: your start and end points are ovals, your activities and tasks are rectangles, and your decision point is a yes, no, because that creates your two arms that you can go off of that with. So if we go back to the one that I created, you can see it does start and end with an oval, and the decision points are in diamonds, creating the flow from there, and then everything else is in a rectangle. Okay, so the next category is tools for organizing information, and this includes driver diagram, affinity diagram, cause and effect diagram, which is sometimes known as a fishbone or an Ishikawa diagram, and then a force field analysis. I'm going to go through a couple of these. The first is a driver diagram, and I created this super general one that I think most of us will probably be able to relate to, and that is to reduce dress size by 2 sizes by June 1st of 2021. So right off the bat, we started with a SMART aim, and then we kind of picked what the main categories that affect that are. And so if you're trying to lose weight, nutrition, fitness, sleep, and stress might be 4 things that you really want to look at. But then from there, what are you actually looking at within each of those categories? Your secondary drivers are kind of subcategories. So if I'm looking at nutrition, that might be, I want to control my portion size, or I want to limit sweets. Those in and of themselves are not change ideas, they're just subcategories. From there, you come up with an actual idea that you can do to control your portion size. So you might measure your food or use smaller plates and bowls. And to limit sweets, you might track with a food journal, or don't keep sweets in the house. So those are the actual change ideas that you're going to implement to see if you make impact on your secondary drivers, then to your primary drivers, and then to your aim. So that's an example of a driver diagram. I was going to create a fishbone, but the Institute for Perinatal Quality Improvement has actually already created this really wonderful fishbone diagram for societal or for problems in perinatal disparities. And so you can see how they went through the big key categories that would impact this outcome. And those are societal factors, community factors, relationship factors, and then individual factors. And then within each of those categories, they came up with specific ideas that are at play affecting perinatal disparities. Okay, the next category is project selection tools. And a few that I am going to talk about, all of these actually: a prioritization matrix, a failure mode and effects analysis, and a gap analysis. And so the first one is a prioritization matrix, and that helps assign priorities based on a sum of scores given to various considerations. So those might be, how feasible is it to do this project? How expensive is it to do this project? And how important is it to do this project? So here, those that are very important and also very easy to do would be what you want to start with. And those that are not very easy to do or not super important would be ones you would do later. I do want to stress that if your data shows a large disparity, that should weigh heavily on the importance of doing that. Here's another example set up a little bit differently, where you have several different options and you actually score them and then calculate your scores, and you want to make sure you know the direction of importance here. So making sure that if one is the top priority, you keep that consistent throughout so that your scores end up making sense at the end. But then at the end, you just basically pick, okay, which has the lowest score or which has the highest score, whichever one you went with, to determine where you start. Okay, the next one is failure modes and effect analysis. And this is a preventative approach to identify and address any potential errors. And so it starts with a flow chart like we just went through, and it highlights every single step in a process. And then it looks at each step, and these aren't just the decision points, but every step in a process. And it asks, okay, how might this fail? What could go wrong at this particular point? And then from there it asks, okay, if that happened, how bad would that be? What would be the effect of that failure? And then it calculates a hazard score that's based on severity and probability. And there's actually a calculator on the IHI's website that helps you do all of that, because it can be a little complicated if you have a process that has like 17 steps. But I did want to give one more example. This is a very, very, very basic flow chart that talks about the process of waking up and getting ready in the morning. Starts with the alarm ringing. Are you ready to wake up? Will you be late if you hit snooze? If those are no, then you hit snooze. If you're not ready to wake up or you will be late, then you get out of bed and you turn off the alarm. Now, if I were to continue this flow chart into the next process, it would involve daily hygiene, which would include showering, putting on deodorant, brushing teeth, things like that. There is one example where you might bypass importance and feasibility if it's both super, super easy, super, super quick, and super, super inexpensive. So let's say I've identified forgetting deodorant as a failure mode. That's not very likely to happen because that doesn't happen to me very often. It's also not a huge deal if it happens, especially now that I'm working from home, but even still, you'd have to get really close to me to realize like, oh, I think you forgot your deodorant. So it's not a huge deal and it's not very likely to happen, but it also is a super, super easy fix. I can grab an extra deodorant, throw it in my work bag, I can throw it in my desk. There, done, don't have to worry about that failure mode anymore. So if there's something like that that you can just really quickly cross off the list, go ahead and push it up to the top of the prioritization. Okay, and then the last one is a gap analysis. And this compares your actual performance with your desired performance to identify gaps. And so I created this one. This is the recognition component of reduction of peripartum racial ethnic disparities bundle from the Alliance for Innovation on Maternal Health. And this is super easy to create. You just lay out what your best practice is and what the strategies are involved in that. And then you identify if your practice is in line with that or if it's different. And if it's different, then you identify, well, okay, well, what's in my way? What's in the way of making it happen? What barriers are we going to experience if we try to implement that? And then you determine if you're going to implement that best practice or not, and why or why not. Okay, so the last thing I want to talk about is PDSA cycles. And these are a way of testing and documenting a change. And this is where you really get into that cyclical process. This is where you implement something small, you go, you do it, you see what happens, you see what worked well, you see what didn't work well, and you go back and you do it again. This is not creating a policy and implementing it to the whole entire staff and then later on finding out what went wrong. So I'm going to go through each component individually. And so you start with a plan, and that is including not only the plan for the test, but also the plan for how you're going to collect the data. And so you want to state the objectives to start with. What questions do you want to answer? And then you want to make a prediction of what you think will happen. And then you lay out a very detailed plan of who's going to test this, what is going to be tested in this cycle, where is it going to be done, and when is it going to be done? And then you identify what data you'll need to collect to be able to answer if it worked or not. The next step is to actually run the test. And again, this is on a small scale. You carry out the test maybe 2 days a week, maybe with maybe in labor and delivery, but not mother baby. You pick something small and you carry out the test. And then you document what happens, any problems that you encountered, any unexpected observations, anything that came up that you didn't predict would happen. And then you begin to collect that data and start to analyze it. And that leads us into the next step, which is study. And that's when you start to really analyze those results and compare them to what you thought was going to happen. And so if possible, you want to do this as a team because different people have different perceptions of how it went. You compare your data to your prediction, and then you summarize and reflect on what you learned. And that leads you into the next step, which is to act. So once you've determined how it went, you can determine one of 3 things. Hey, that went really well. Let's adopt that change and test it now on a bigger scale. Or you can say, hey, that didn't work at all. Let's go back to the drawing board and start over and abandon that change entirely. Or you can say, well, that kind of sort of worked, but I think we might need to tweak it a little bit. So then you go back and you make a few modifications to it, and then you run another test. And again, if you're doing it that way, just adapting a change, you want to test it again on that small scale. You don't want to go larger at that point until you've figured out on a small scale what is really working well. And then you start the process all over again and you run through it again. Okay, so I know we just covered a lot and we have a lot more to cover. So we're going to give you a quick 5-minute break. If everyone can be back, actually we'll make it 8 minutes. If everyone can be back by 2:15.
All right, welcome back, everybody. We're going to go into the next section of our workshop. I've been tasked with kind of talking about QI data. And as we're going through the presentations from Christina, Amanda, and Carrie will take a deeper dive later. Data is going to drive everything that we do for QI initiatives. So it's really important to kind of have the right language and thought process and definitions as we go forward. Sorry, my phone is making noise. Okay. Of course, I can't advance. There we go. Okay. All right. So our objectives for the next little over a half hour is to differentiate what quality improvement is related to research. Always a question that comes up, especially when we look at going to IRBs and those kind of things. We're going to talk about understand the use of data for QI, and that's going to drive those PDSA cycles that Amanda talked about. We're going to talk about various techniques for collecting data, everything from automation through EMRs to manual data forms that we create and enter manually into an Excel spreadsheet. We're going to talk about the importance of collecting real data, the race, ethnicity, and language data to allow us to create subsets of outcomes and patients to look at outcomes in to see if we can evaluate our quality improvement efforts from a different perspective. And then we're going to talk a little bit about how to employ and depict the real data for our QI work. So Edward Deming is the father of modern quality improvement efforts. And this is a great quote he has, and I think it really speaks loudly to what we do in quality improvement. In God we trust, all others bring data. So if you don't have data, you're just talking into the wind, and you really have to use the data to teach others, inform others about what changes are needed or opportunities for improvement are there. So first, let's talk about research and quality improvement. So we're all pretty familiar with the research realm. The purpose is to discover some new knowledge. Oftentimes research, the test for research is to have a group that's blind or some group that's a placebo, another group there's an intervention of some sort. The advantage of research is you can potentially control biases. So a randomized trial is the holy grail. You randomly assign people to placebo versus intervention group. The randomization process takes away those biases that might be there in the background. If you do a cohort study, you can control for biases either by selection of patients or after the analysis, control for those biases. Research, usually the motto is collect as much data as possible, just in case you need it, because you might want to look at some subgroup analysis or something later. And the duration of research can take a long time or be pretty involved and quite expensive at times. In contrast, though, quality improvement efforts, it's something the purpose is to bring new knowledge into daily practice. How can we take something we're doing today and make it better for the benefit of patients and care from the medical standpoint? So that's really the driving principle or purpose for quality improvement efforts. The tests are many sequential and observable tests. That's those PDSA cycles that Amanda talked about, and Carrie will talk about more at length as we go forward through the rest of the presentation today. Biases, though, we try to stabilize them from test to test, but it is what it is. Your population you care for, the effort you're working with, you're kind of fixed with whatever that population is. So it's a little harder to control biases and quality improvement. You just have to acknowledge they're there and kind of account for that in your analysis and description of your data afterwards. The data collection for QI improvement is usually just enough data to learn what metric you're focusing on, whether your intervention worked, didn't work, or some of those modifying factors that may be as part of your Pareto chart that we'll talk about later, so that we can do our next PDS cycle, make a modification and adapt and move forward with another cycle of our quality improvement to see if we can have sustainable, meaningful change. And then the duration of the project is for quality improvement, a really small test of change. We don't want to do a million different things at once, although some of the bundles get into that approach, because you never know which one worked, right? It could be the one intervention you did as part of the bundle that dominated everything, whereas the other stuff didn't mean as much. So it's really smaller tests of change to accelerate the improvement process. But you turn those cycles around quickly to see that work, didn't work. We make another adaptation, do another PDS PDSA cycle and then kind of cycle through until we get the improvement we want. And then most importantly, as we'll talk about later, sustainability. How do we keep that change in place so that it don't fall backwards, and can we move to the next level beyond what we just accomplished? So data for QI is really important. So it's the foundation of everything we do. Demonstrates how well systems are working together, identifies variations in processes, and those variations in processes often are opportunities for process improvement potentially. Data, it helps establish a baseline before changes are made and implemented, and it shows the effect of change after we've made intervention, that we can actually show to stakeholders, hey, we did this intervention, you invested in us to take on this initiative to reduce wait times or improve care, per scanning scores, those kind of things. But we did this, and here's the result we have it. And it's going to be really that data that's going to help drive decisions about sustainability, maybe hiring additional support individuals for a clinic process, or developing policies and procedures or guidelines that might be helpful to improve those practices and sustain them. So this whole session today really has an eye on the health equity lens. And it's really important to think about health equity when we're looking at quality improvement projects, because we all know the disparities are there: ethnic, racial, language barriers, differences in outcomes. We've seen from the Texas Morbidity and Mortality Report, there's significant ethnic and racial disparities in severe morbidity and mortality, hemorrhage rates, hypertensive disorders. So it's really important to think about that in our quality improvement efforts. So the graph on the left side of the screen shows just kind of, if we observe the big dashed line is improvement in quality of care. Well, that could be from a lot of things could be happening there if we, behind the scenes in this, with the disparity lens. Either we could be seeing the quality of care improve, but disparities increased. There's much worse outcomes, or we didn't see as great of an improvement in certain racial or ethnic groups. So that would be something we'd want to know about, because that may be a future opportunity for us to focus on, to really look at why didn't that increase as much, and why did that disparity increase more, and what are the opportunities in that group of patients that we might want to focus on for our next PDSA cycle. The second possibility is we see improvement in both, that the disparities stay the same. We've always had them in the background. We did improve quality of care, but that disparity maintained itself. And the third possibility is we improved quality of care, but actually reduced the disparity. And that would be something we want to embrace and try to build that into our next PDSA cycle, or build it into our sustainability models going forward. So looking at the disparities is really important to consider as we look at our data and look at our trends as we move through run charts and analysis of our data. So Amanda mentioned a little earlier the real data concept, to really start to look at, in addition to all the information we're going to collect about outcomes and factors related to a given outcome that we're trying to impact with our quality improvement effort, but to start including race, ethnicity, and language into that. And those are really critical to illuminate the nature of the disparities that we see, so that we can address them and try to look at targeted approach to reduce and eliminate those disparities that exist. So we need to all start to think about a systematic process to collect accurate, self-reported real data for our quality improvement efforts. And it's important, it's probably self-reported, right? Because the patients come into triage or come into our clinical settings. The only reliable way of documenting race, ethnicity, and language is self-reported from the patient. And that can be challenging sometimes if there's a language barrier, or our EMR doesn't have the right fields to account for the different categories we want to look at. So there's 6 dimensions of real data. The first is timeliness, the degree at which data is available at the time it's needed. That's obviously really important. If we have to wait a couple of months for data to come out of a EMR report, that's not going to be super helpful for real-time adaptation of our PDSA cycles. Second is completeness, the degree to which data is available for use. That kind of gets into our, do you have fixed fields in your EMR for race, ethnicity, language, or is it just if somebody fills it out, it gets filled out, or maybe there's some fields that are missing, and that gets to be more difficult to analyze real data. The uniqueness is another factor, the degree at which data is unique and cannot be mistaken for other entities. consistency, the degree to which data is equal within data sets. So that kind of comes down to training your staff to make sure they have the same approach to collecting the race, ethnicity, and language data. Validity, the degree to which data is within defined requirements, format, type, and range. A free text field would be very challenging to get good validity, whereas if you have checkboxes, that can definitely increase your validity, as long as your staff are trained to know what those different fields mean and how to fill that out. And then lastly, and probably most importantly, is accuracy, the degree to which the data represents reality. If clinic's busy and there's somebody not educated or hasn't been trained about what fields to click, and they're just clicking boxes just to get the chart closed, the data may be there and you may look at it, but it's not accurate and won't be very helpful. So it's important to consider all 6 of these dimensions as we think about real data. So what are some of the barriers to collecting real data? Lack of standardization of categories. The NIH has some very robust definitions for race, ethnicity that can be used and incorporated into your EMR. There can be limitations on information technology. The fields that are in our EMR, whatever platform we're using, may not match the standardized definitions the NIH or others are using. And we may need to work with our IT folks to improve those definitions so they match either standardized definitions or definitions that we've created that we found important for our facility or our unit. A lack of staff understanding of why the data is collected, that kind of goes back into that training aspect I mentioned further. It helps for the staff to know not only how to do it, but why are we doing that? Are we doing it because we want to collect information on language? And could there be a misperception that that's being reported out to ICE or some other entity that could potentially bias the patient for care or cause problems from them for other reasons? Is there staff discomfort about collecting the data? And that kind of goes back to informing them why it's important, informing them that it's important for us to really understand why disparities exist and what opportunities do we have to improve that. But if the staff aren't familiar with that understanding background, they may be uncomfortable asking questions about that. And then obviously patient privacy concerns, how is this data being used from their perspective to actually report accurate data, whereas they might say something different if they think there might be some concerns about privacy or legal issues or immigration status, et cetera. So as I mentioned, it's really important to train staff that collection is specifically going to be used to reduce health disparities. We need to develop systemized collection processes and educate our teams about what that looks like, or develop patient-directed tools to collect that self-identified real data. And it's really important, as I mentioned, to reassure patients that the collection is voluntary, it's confidential, it's confidential, it's confidential. It's only to be used for improving quality of care and not be used to determine whether a patient has insurance coverage, payment, discrimination in any way other than the quality improvement focus for that data. So that's a message that really everybody on our team needs to know that so that they can reinforce that if a patient asks about, well, why do I have to tell you that? Or they seem apprehensive about reporting their language or race, ethnicity, we can inform them that that's the reason we're doing it, and certainly no punitive reasons to provide that information. So the advantage of looking at real data allows us to look at the impact of care in our quality improvement initiatives in a single subgroup rather than in a mass together. And from that, we can generate different looks at our quality improvement approaches or opportunities for interventions related to the different ethnic racial groups. So basically, stratification is dividing data into subgroups that have a common property. That could be race, ethnicity, language, but could also be male or female, smoker, non-smoker. You could think of a dozen different ways to break that up. It's common to combine one common property to create a more detailed subgroups like non-Hispanic white, non-Hispanic black, Hispanic white, Hispanic black, and those are similar to some of the NIH definitions. When we do our analysis of data, the response variable is the outcome, and that's in that subgroup of patients that you're looking at. And the denominator is the number of patients within that subgroup and not the total number of patients altogether. So that's really important as we're calculating those outcome ratios or rates, that it should be the number of patients in that subgroup who develop a certain outcome or experience a certain outcome divided by the number of individuals within that subgroup, not the overall group. And that's shown here in this slide. So stratification is not taking the number of patients with the subgroup who experience the outcome divided by all the patients. It's actually the number of patients in the subgroup who experience the outcome divided by all the patients in that subgroup. So example there would be prostate cancer in men. So there your stratification is by gender. Your outcome is prostate cancer. Your number of patients in subgroup X, which is men, would be your denominator. So the denominator is all men, and the numerator would be all men with prostate cancer. It wouldn't make sense to include all patients, men and women, in the denominator, because that wouldn't make any sense, and the outcome measure is not very meaningful in that setting. So there are some data analytic platforms out there, and I think Christina's institution uses the QLIC Sense program. A lot of us fall back on Excel. Excel is very robust, but it requires a lot of manual work putting data in and to generate reports. There are programs you can link with it. QI macros can be brought into that to create run charts and other accents to Excel to graphically show your QI data. That's helpful, but it is very labor intensive to use Excel. So if you have capacity or you're interested in learning more about the data analytic platforms, certainly look into those, because it certainly could streamline your approach for your QI initiatives. So this is just a schematic, just to kind of show kind of what we talked about a few minutes ago, making sure you're using the right denominator when we're analyzing real data in Excel. So these are your columns you'd have, and the denominator down here on the left, shown in the light orange, is basically all the patients overall for the entire population. And then the different colors are your subgroups. This is non-Hispanic Black, non-Hispanic White in blue, Hispanic in green. But you'd make a mistake if you were dividing each of those subgroups by the total denominator, when reality is on the far side, on the right side, you should be dividing each subgroup by the denominator for that subgroup, so all patients within that subgroup. So this is just an example looking at some of the Muse data that we've had, showing some differences we've noted by looking overall. And then when we break it down by race, ethnicity, to see the differences exist related to those disparities. So overall for the Muse trigger in this example, the median time to response was 55 minutes. But if you looked among non-Hispanic White patients, it was only 30 minutes for response time, but non-Hispanic Black patients, 75 minutes, a marked difference. And you can run statistics off that to show that may or may not be significant. And then Hispanics had 60. So if you didn't look at these different subgroups by real data assessment, you would miss those potential opportunities. So here we have, looks like we're doing well in the non-Hispanic White group, but why are we seeing the higher delays in response to or return to a non-normal, non-trigger range vital sign in the Muse effort in these other subgroups? So that can inform us for additional quality improvement initiatives. And this is showing another way we can depict graphically is just over time. These are the different racial ethnic groups. Let me get this up here real quick. And showing the return to vital, or this is an abnormal vital sign to have provider at bedside data. And you see the non-Hispanic Blacks have a much longer time than the other racial ethnic groups. So again, a significant opportunity to drill down on why are we seeing this delay? What are the opportunities there? And as Carrie goes through her example in the next session, she'll kind of use some examples to show how we can use this equity lens to inform us to drill down and have tangible impact on all care for all patients. So the Health Research and Educational Trust Disparities group has a toolkit that helps kind of define our framework for stratifying real data, and the link is at the bottom of the screen. And they define a 5-step approach for stratifying real data. Forming a work group up front, it's focused on the health disparities data, trying to look at what that should look like, what are the definitions that should be used, what data elements are going to be collected, what outcomes are we going to focus on. Develop a process. Second is to develop a process for validating the real data. This is self-reported, but we need to make sure that the patient's self-reported data reflects what's entered into the chart and into the EMR. Third, identify the highest priorities for metric stratification. Which subgroupings or groupings of patients should we put together for those racial, ethnic, or language groupings? And then fourth, determine if stratification is possible for certain metrics. Maybe we can't do it for some patients because either we have too few patients, the data is not reliable, not validated well, and we can't look at that. So that's important to consider that. And then last, once we have all that figured out, then stratify the data and start to use that in a meaningful way in our quality improvement initiatives. All right, so analyzing by real data, stratifying outcomes by race, ethnicity, and language will help us identify disparities, as we mentioned. Really takes a team to do this, and it can't be just us as OB/GYN providers or public health providers or nurses or other individuals in their isolated silos looking at this. They really want to get a diverse group of individuals together to have a different lens looking at the different issue you're looking at to see what you need to analyze and how we can potentially address ethnic health disparities. And that's core to any QI initiative. You really do need to have a multidisciplinary group looking at the issue at hand or the focus of the effort by different lenses. Because if you just have us look at it from this direction, I may miss tons of opportunities behind the scenes of things I'm not even aware of that happen. And by having a diverse team together, you can really drill down on that and be very effective. Having dashboards is helpful, and I'll show you some examples of that in just a minute that include race, ethnicity, and language data. And then share data depicting these healthcare disparities with stakeholders. And we'll talk about different ways we can show data toward the end of my presentation. And that's key, because if we can't sell the story, we can't pitch our take on what's going on to the stakeholders who have to invest a person or invest money or invest resources for our quality improvement initiative. We will just flounder and not get very far. We need stakeholder buy-in, and we need to use data to show that to the stakeholders to reinforce why it's important and share our successes and our failures and how we use those failures to move forward with additional opportunities for improvement. So the model of improvement, and you've heard this earlier and you'll hear it again as Carrie comes on a little bit later. The model for improvement is, what are we trying to accomplish? How will we know that a change is an improvement, and what change can we make that will result in the improvement? And that's through development of a SMART aim, as Amanda talked about, developing a robust data strategy, which we're talking about now, and then the PDSA cycles that Amanda talked about and we'll talk about further later this afternoon. And that's my dog in the background. So what types of data do we have for QI? So there's different types of data that we look at. There are structure measures, and those are things that are related to the institutional or organizational infrastructure, our capacity, systems, and processes that may be in place. And I'll give you some examples in a moment. Processes are the ways that we deliver services or the activities that are done to provide care. Outcome measures, that's kind of self-explanatory, the overall impact or results of the care provided. So that's kind of the main metric you might focus on: reducing wait times, improving patient satisfaction scores, reducing response times for muse triggers, and those kind of things. And then balancing measures, we always have to think about, are there any unintended consequences of some intervention we're proposing that may be something we need to consider. Example, at our institution, we did a big transfusion reduction initiative, and we built in a process for patients who failed initial treatment with oral iron to have IV iron administered. But initially, we didn't consider the transfusion center capacity nor our triage capacity to handle those patients when they came in. And when that rolled in and they started to become overloaded, we realized that that was a really big issue we hadn't thought of. So that's an important balancing measure. What are those other things you might not have thought of that could have a negative impact on your intervention? And you have to address those and track those as well as part of your quality improvement project. So this is some examples from the Muse project that was just completed by the collaborative. Some of the process measures there, a proportion of OB providers who had educations on the Muse protocol, proportion of OB nurses who completed training, number of all the cases that triggered a Muse protocol, all cases that should have triggered a Muse protocol, all cases that should have triggered a Muse protocol but didn't, a number of deliveries after 20 weeks, excluding ectopics and miscarriages. So those are the process measures. Structural measures would be just having a policy, yay or nay. Do you have Muse triggers included in your handoff reports, yay or nay? So those are bigger institutional unit type measures. And then outcomes for Muse are time to abnormal vital sign, to have a provider at bedside, activation of an order set, time to activation of the order set, time to abnormal vital sign to return to non-trigger range vital sign, transfusion of 4 units or more per 1,000 deliveries, or intensive care unit admission. So just some examples. And ask for help as you guys are working through quality improvement projects. Don't be afraid to call out to any of us or any of your local experts at your perinatal care region that can help you through these, defining these different measures, et cetera. So data collection, it's really important to have a plan and strategy in place before you start it. I think the biggest mistake people can make is just launching into something and they hadn't really thought through, well, how are we collecting the data? What does that look like? What's the reliability of the way we're going to collect it? Who's going to collect it? Who's responsible for it? Where's the data getting entered? What's our analysis plan? How long are we going to analyze for? Second is include some qualitative data and some quantitative data. So time to response is important, kind of a quantitative type data. Qualitative is response to a Muse trigger. How often did that happen as a proportion? Create a way to run reports from either EHR or if you're manually collecting data and connecting chart audits, how are you going to report that out either with Excel or QI macros or some other platform? What do your data collection tools look like, and make sure those are vetted so that other people understand what your field X it really means. Is that mean this or does that mean that? So it's going through some kind of validation step to make sure that your understanding of what that question is the same what everybody on your unit understands that is. And then random sampling or sampling everybody is another thing to think about as part of your data collection plan. So I mentioned qualitative data and quantitative data. That's pretty self-explanatory. Quantitative data is where things are counted. It's a continuous variable. That's number of patients, number of fallouts, temperature, height, weight, any time to response for a Muse trigger or return to normal blood, normal vital sign. Qualitative measures are like data from observations, interview, checkbox kind of things. You can convert qualitative data into quantitative data using Likert scales, like how do I feel about this, pain scales, patient satisfaction scales. Those are qualitative things, but you can make them more quantitative using Likert scales or some other approach to that. So data plan, what are we measuring? Why are we measuring it? What's the purpose? We gotta have a clear purpose for measuring it. What does the data look like? What type of data is it? We have to have a really clear definition to make sure everybody understands that what the definition is. Because if I say even active phase arrest and labor or labor arrest, that's pretty ill-defined, right? Labor arrest, could that be a second stage arrest? Could that be active phase arrest? Could that be a failed induction? So you really need a really clear, crisp operational definition that everybody on the team understands so that you can make sure the data is reproducible if somebody else is collecting data on the next day. Define your sources of data and how you're going to collect it. Define who's responsible for it, how often you're going to measure it, and how long you're going to measure it. Is this a 2-month protocol? Is this a 2-week PDSA cycle? What's your plan for initial implementation and data collection for the first wave, and then revisit that as you go forward. So this is just an example data plan that we'd create for a project. We'd create a table, what data we're collecting, types, and kind of define that, and who's responsible, how often we're going to collect it, and those type of things. And it really helps you kind of get organized about your thoughts about how this project is going to unfold before you actually start it, rather than doing it post hoc once you've started the project. Now you're trying to figure out who's going to collect it and have debates about those type of things. So this is an example from the Muse project from the collaborative. looking at the different, what types of measures there were in the first column, how often was the data submitted, how was the data collected. REDCap's a real powerful data collection system that can be used. So if you're not familiar, we certainly can provide you some information about REDCap. A lot of institutions have access to REDCap. It's through Vanderbilt. So you can certainly get access to REDCap, but SurveyMonkey and other tools could be used as well. What is your title of your measures? Where's the data coming from? And then your definition. What's your numerator? What's your denominator? And have a great precision on what those definitions are, so that everybody on your team can look at that definition and reproduce it as they go forward. So a way to think of that is a RASCI model. So think through this. R is for responsibility, who's going to be doing the work. A is accountability, who's accountable for the work. S is for supportive, who do we need to help the person responsible with that data collection or with that data element. Who do we need to consult with? Who has that expertise and can help us define, make those definitions or improve the validity of a given metric. And then informing people, make sure everybody who's affected by this activity knows why we're doing it and what the importance of it is and what the definitions are. That goes back to that education that I mentioned earlier. So here's just an example, another diagram we would create before a quality improvement project, just defining who the different players are on our team and what their different roles are. Definitely your chief of service or your division chiefs should know what's going on. Your nurse CNOs should know what's going on, just so they can be supportive as needed. The last thing they want to hear is through back channels through the quality department that a project's being done on the unit and and they haven't heard of it. And that's bad form if we haven't kept our whole team involved with that. So definitely want to develop a real clear plan for who's doing what with your projects. So I'll just go briefly through some of the data collection approaches and then show you some different ways we can show data. Tally tick sheets. We used to do that when we're going through like voting and things. You can do little tick sheets to count off things, very rudimentary. But you can do that. You can do that in Excel by filling fields in and then do sum fields to calculate sums for you can take some of that manual labor away for counting. It can have check sheets and forms. Again, you want to validate your forms, make sure it's collecting the information you actually mean it to collect. You want to observe, you want to have feedback, could be written or verbal, and then questionnaires could be used or interviews as well as part of your data collection. Things you can think about, probability sampling. So that's where you basically any person in the population you're looking at could have a chance of being selected. And then your results are probably generalizable as long as you don't have a bias about how you're picking the person or the individual, the chart you're looking at related to like a Muse trigger or something, then you should be able to generalize it. If it's something that's not probability based, so you're just kind of not every patient has the same equal chance of being picked. Like we'll look at patients on Mondays every week. That's probably a non-probability sample because if Dr. Smith is on and Nurse Jones is on Monday and they do things a totally different way than Nurse XYZ and Dr. XYZ on different days does it, that's not a non-probability sample. There's a lot of bias in that. So you really can't generalize those results from that sampling on a Monday to the whole population potentially. So really be thoughtful about how you're going to sample charts if you're going to do a sampling. And when we look at Joint Commission and we look at Leapfrog, some of that is sampling. And theoretically, that's a probability type sample, although the numbers are small, so you have to be careful about those small sampling. So QI charts and graphs. So that's really how we're going to sell our story. We're going to show what our baseline is, so where we're starting with, and assess and prioritize our needs for improvement. We're going to look at the process from different perspectives. That's why looking at through the real data lens, race, ethnicity, language is helpful to look at that a different way and engage different stakeholders in the way we're looking at our graphics. Understand and analyze the data, and then really important, portraying those results to stakeholders is critically important because you really need to maintain and gain that stakeholder buy-in to support ongoing efforts. So how do we want to display our data? It has to be organized, be validated data, summarizing data that's in a consistent way, easy to look at, easy to interpret. Your slides should stand on their own. The display will change depending on who your audience is, right? So if you're talking to your senior leadership and you're trying to make a pitch that we need some support related to this, you're going to provide a real high level overview, and you're going to target your presentation to show data related to whatever that ask is. Whereas the data for your day-to-day shift, just to see the real-time changes on the unit, you may want to show a little different level data so that people can truly see what's going on a day-to-day basis. So really think about your audience and really think about what you want your viewer to take away. And that kind of goes back to your ask. If you're planning to push the quality improvement project forward further, and you're going to propose this next intervention to be the next step for your PDSA cycle, your data should show why we think that is. Your Pareto chart should show these are one of the top reasons we're going to focus on this and this effort in the next cycle. And this is why we're going to do it. So it really has, the graphics are going to be used to inform our viewers, whether that's a senior leadership person, part of our team, division chiefs, other stakeholders that may have a stake in the matter. So this is just an example, one way you could show things. This is from the State Morbidity and Mortality Committee report this year. And basically they showed in the blue a good chance to reduce outcome, the adverse cause for maternal death, red some chance, or green no chance. So graphically you can look at that and see there's a big chance that some are good to strong chance that we could have an impact on all these events that led to maternal death. So that's a pretty powerful way to show that data. This graphic just shows pregnancy-related deaths per 100,000 live births broken down by ethnicity and race, and showed pretty striking differences. So you could certainly use this type of graphic to show we need to focus on some ethnic or racial groups related to that adverse outcome. And then here's a linear graph over time just to show how sustainable different disparities were. The upper purple line shows a very high rate of severe maternal morbidity compared to the light blue line, which has a significantly lower rate of severe maternal morbidity. So you can use that data in a very powerful way to inform your stakeholders and sell your story about why we need to focus on this and why do we need to invest time, personnel, and resources toward this initiative. And this just shows the dashboard that we talked about a little earlier. You can get pretty sophisticated, just kind of, this is looking at language and outcomes. Language in your delivery population on the far left, language by SMM rate in the middle upper part, number of deliveries by language, and then the bar graph or the line graph at the bottom shows the severe morbidity rate over time in the different language groups. And again, you can sell your story and highlight why we need to focus on a given issue going forward for our initiative. I'm going to skip that slide. Just shows again why it's important. If you don't look for disparities, you won't see them, and they may be very insightful about why we're seeing certain trends. So really think about focusing on that. So the commonly used charts I'll just finish with: run charts, histograms, pie charts, Pareto charts, and scatter plots. So run charts are basically a line graph of data plotted over time. Shows how much variation a process exists or if a process is changing significantly over time. And we can use to track that as we implement our project. We use 4 rules of change to track change for improvement or degradation, and I'll show you those in a second. Those are called shifts, trends, runs, or astronomical points. The run charts use a measure of central tendency. Remember that from high school? Means are the average values. So you take all the numbers and you average them. Mode is basically you line up all the numbers, and the number that shows up the most frequently is the mode. And the median is actually you take the extremes and you march your way in, and then the number you come out of the middle is your median. So those are different ways you could depict data. There's no right way to go for that. So here's an example of a run chart. The line in the middle is kind of what the average of all the data shown on the screen. And this is a graphic of missed muse triggers. And you can see how over time it goes up and down. So that's what a run chart might look like. A shift is basically when we see a drop or a change in the run chart that is sustainable for at least 6 different data points above or below whatever the trend line was. So this is an example of a shift. A trend is when we have 5 or more points that are heading in the same direction, either up or down. So we would call that a trend. So this is an example of a trend related to Muse triggers. An astronomical point is just an obscure event. What happened in August? Was that our new AMR? We launched Epic that month and nobody knew what anything meant. Really can't explain it very well, or if you do explain it, it's truly an anomalous variable, so that'd be considered an astronomical point. And then this is just kind of the example of all together. Here's the baseline run chart. Here's a trend going down. Here's a shift in baseline, and there's an astronomical point we might see in one of our graphics. Pareto charts are really important, and Carrie will go into this a little bit later in her part of the presentation. And these are really important to focus on. These are bar charts showing the frequency distribution of all the variables that affect the process. And you rank the bars from most frequent variable encountered to the least frequent. And it really helps you give an idea of what's going on with your system if you don't see improvements in your run chart. And there's a rule called the 80-30 rule that we should use to help prioritize our focus. And that means that 20% of the things we identify as potential variables are causing 80% of the problem. So that's where we want to spend most of our effort, on that 20% factor. So here's an example looking at medication errors. These are all the different things in the lower axis that show why we'd have a medication error. And the top 4 were missed dose, wrong time, wrong dose, overdose. And if we focus on those few, we're going to account for 80% of those events where that happens. So that's where we want to put our money for initial quality improvement initiatives on that area. So it's really helpful for whatever project you're looking on, is to think about a Pareto chart. Histograms are just a nice way we can show graphically one variable affecting a process. All bars are equal and distinct. And it's helpful to kind of get an idea where things are when you don't see an improvement on a run chart. It's not very useful if the process isn't stable. So this is an example for a NICU. If a NICU was going to focus on looking at babies and they tracked what their birth weight was in their baby, they want to make sure they had assets in place to focus on babies that were less than 2,000 kilograms or 2 kilograms. So you can use that to kind of understand your population or your group a little bit better. Scatter plots, they show a correlation between possible relationship of 2 variables. Each dot represents a pairing of data, a Muse trigger versus a response time. And it tests performance if one of the factors is related to performance of another. So it's codependent type variables. And here's just an example, patient satisfaction on the y-axis with doctor time in the office during a consultation. Obviously, as time with the provider goes up, satisfaction goes up. And pie charts for the last couple slides here, just to show parts of the whole. If there's too many parts, it's not very helpful, but if you have 8 parts or less, it's helpful just to show what's contributing to whatever factor you're looking at. It's not useful to track changes of improvement or track it, but they're helpful just to show what might be contributing. And here's just the last example. If we look at Muse triggers, where are these happening to help focus which unit do we need to start our education or focus education. And the Q is, in this case, for Muse triggers, is starting in labor and delivery is the highest, that would have the highest impact, followed by antepartum, shown in the dark blue. And with that, I will wrap up my session, and my phone's exploding. And we will take about a 5-minute break and come back at about 3 minutes after 3 o'clock. And please put any questions in the chat box or the Q&A box if you have any.
Okay, everybody, it's 3:05. We're going to get started again for the final session in the QI course. I'm Carrie Epps. Amanda introduced me at the beginning, but I'm the current TCHMB chair, and I am grateful to get to talk about the implementation portion of this QI workshop. I'm going to do a couple of things. So I'm going to go through things to think about within implementation, drawing in tools that everyone else has mentioned already. But then I'm also going to use the example of COVID. I'm picking that very specifically because I think it's something that we all very much are still in the middle of. But I think it's also an excellent example of why incorporating health equity and disaggregation of data and thinking about social determinants of health is so critical to have a project with a good outcome. In fact, I don't think you can successfully have a plan or monitor data for COVID without measuring those things. So first we'll go through examples related to COVID, and then I'm going to come back and talk about how to make sure you are incorporating components of health equity, reduction of bias, disaggregation of data. So objectives for this portion are really to talk about implementation, how you avoid some common pitfalls, what are important tools to consider, how you use data and those health equity tools we talked about with data disaggregation or stratification, and how this can help decrease racial and ethnic disparities. This is one of the best quotes as it applies to implementing QI projects. And that's a good plan today is better than a perfect plan tomorrow. I think that's just the perfect example for COVID, because I think otherwise you could get paralyzed in waiting for the perfect plan, right? None of us had that luxury. We are in the middle of pandemic, we have to make a plan and then continuously adapt that plan. Better ways to do it, more information comes in, major things change, and so it is impossible to really ever have that perfect plan. I'll just say in that aspect, I think there are two kind of main pitfalls that people fall into with implementation. The first is doing all of the focus on the plan and not the actual implementation pieces, i.e., how are you going to educate folks? How are you going to ensure they know it? How are you going to measure it? Who are all of the stakeholders? What are you reporting to? All of those really important pieces afterwards. Most folks focus on the tool. Maybe they focus on education and then leave everything else after that. And I think that's a major pitfall. The other very common pitfall is data. So either not using data enough or become paralyzed with data. How many people have been in work groups where you've been presented with data and the end result of what should have been a PDSA cycle is, well, we need more data. And then you are constantly asking for more to make your decisions. And then all of a sudden you've gone many months by and have not made any kind of a change. So that data paralysis, I think, is very common. I'm going to talk about implementation using Kotter's model of change. It is my favorite and something that I constantly go back to in thinking about how to implement something. I also know that it highlights every major mistake I have made in implementation projects. And so I'm going to use that to kind of share some lessons learned as we go forward. I'm also going to break it apart into these three sections. So as we go through these first three, which again is where most people stop in a project, then I'm going to take it back and talk about an example of how that can be done with COVID in an ongoing way. At the end, when I've made it all the way through the final steps, we're going to come back and look at that from a health equity standpoint. So the first thing as you are getting ready to implement your project is creating a sense of urgency. Getting folks to understand why this is important. There are a number of different ways you can bring data showing how big the problem is, right? We've seen that in so many of the summits and the conferences we've been, even in this year, with data from our own Texas MMMRC, data that's come forth in other areas, what we have been seeing all year in regards to racism and the inequities in healthcare. Literature and evidence strategies are always really important. You don't have to think about them from multiple other sources. And then patient experiences. There is nothing more motivating than an actual person's story that has been in your hospital showing what is going on, or in your clinic, or in your community. You know, this is happening to the people that you know and that you take care of. And so those patient stories are actually, in my experience, even more motivating than data or to different groups of people. When we got ready to implement Muse, and talked about it for almost a year before we did it, in trying to bring that sense of urgency so that folks were on the same ship with us as we started to sail it. So sometimes this is taking what is the problem you're trying to solve. In particular, thinking about it with a health equity lens is adding each of these components. So we've been working on postpartum hemorrhage as our state for the last several years. We're about to start on hypertension. These are huge examples with plenty of evidence and data behind showing the huge racial and ethnic disparities in our population of patients. The same thing with COVID, right? So if the problem you're trying to solve is related to morbidity in certain groups, making sure you are also equally addressing and paying attention to the effects of healthcare disparities within that group. So if it's postpartum hemorrhage, the effects within that. The next part is your team. So creating your coalition, your group of people who's going to go along with you. Often you are adding more folks as you are moving forward in your project and expanding the scope. You want to create support within your environment. So I think it's really important to include whomever might be your biggest naysayers in that team, so they are part of making you make a really good plan as you go forward. And especially as we're talking about equity, there's nothing more important than culture. So who's on this team? There are a lot of different ways you can create your team, but I think one of the most important things is role clarity. I just had a meeting the other day with a group of people, and I thought we had kind of all come into it knowing what we were talking about. We were talking about our education and simulation plan and how we kind of do that in all of our different projects. And then we got to the end of the meeting and I said, oh, by the way, you're here because you are the director of education and the director of simulation. And everybody looked at me like, oh, that's what we're doing. And I realized I had just had an entire meeting without role clarity and objectives and kind of lost the last 45 minutes. So if they're there, make sure they know why and how to be helpful. They probably will tell you ways they could be helpful and contribute that you haven't even thought of, but make sure that there is role clarity, right? For anybody who's read Brene Brown's Dare to Lead, the concept of clear is kind, right? This is what I'm wanting you to do very specifically. These are some examples, especially as we're talking about projects that are aimed at reducing bias and improving equity. There are many of these are things that you need in your area for whatever QI project. Something very important based on kind of what Pat was talking about earlier. If you're trying to have good data about what your true outcome disparities are, you need that good data. So involving your admissions department, if you've done that years ago and you know you have accurate assessments of race, ethnicity, you're assessing for social guilt, feel pretty good about it. They might not need to be in every project that's focusing on health equity, but they certainly do in the beginning. And the other really critical thing that we're all learning how to do is the patient's voice. We know we can't assume we know what the problem is. You need to actually ask the people who we are taking care of and their experiences, and that critical part of patient experience in a lot of what we're looking at. I'm going to go a little bit on a tangent. In some of these meetings, you can be the most brilliant QI expert, but if you aren't good at facilitating a meeting and having requirements organization, it's not going to go as well. I was just discussing with someone the other day. Usually if you're having a meeting with a PDSA cycle, or you're having your coffee meeting, most of the work and the total time that you're spending, the actual meeting is the minority of it. Without an agenda. Don't forget to involve people ahead of time and contribute within it. Don't come without being prepared with data and what the problem is and what the goal is and what you're trying to solve. Sending notes afterwards and action items so everybody knows. Start on time. I am a horrible moderator and facilitator. I get so involved in listening to what everybody has said that long ago we learned I cannot be the one in charge of time, or everything's going to go over in a lot of our quality and safety meetings. So if you know that about yourself, have somebody else responsible for it, because everybody's time is really valuable. So the way you run meetings and think about them needs a lot of thought as well. So stakeholders, and I'm going to admit a lot of what we're talking about here is the people who are supporting you to do your projects. So is that your administration? Is that your leadership? You want to make sure that they understand what you're doing, why it's important. You want to give them regular feedback. You want to make sure you paint the path for why it's important, and that will keep them engaged and keep you successful. You might not need to have them in every meeting. One of our hospital leaders in the beginning of every new committee usually comes for the first meeting to kind of see how it's laid out, and then might not come after that. That's really important. That means that you need to know what you're doing in that first meeting and be organized enough for them to see that it's a valuable project. Culture is an important thing to talk about. It's even more important as we talk about equity. For those of you who did the session this morning, I think so much of that was how do you make sure that everyone on your team understands why health equity is important? How do we make sure our population is focused on it? It's going to be hard to be successful to move the needle on improving outcomes if the people you are working with aren't bought into it. And so that is a very long and involved journey that we're all on. For implementation, I'm not going to focus on it as much, except for a couple of key things for just in general implementing projects, because people have done such a good job with it this morning. So as far as sources of influence, something I first saw in our Society of Maternal Fetal Medicine, they do a leadership course every year, and it opened up my eyes to understanding. Over and over, you'll hear that groups might not have buy-in, they might not be engaged, they might not be participating. I hear it a lot with physicians not coming to the table for QI projects from nurses. Or on the reverse, the physicians really want to do something and don't understand why somebody is being a barrier to them, right? We use these terms. We also use it a lot as we're talking about the concept of patient non-compliance, which we know is a completely made up term by the medical profession, and usually is a label we're putting on because we don't recognize the barriers we're creating. So this is an idea of how you look at these 6 different sources of influence. If someone is not helping you with your project, if your culture isn't where you want it to be, why is it? It's usually a combination of motivation and ability. COVID was so much about ability, right? I was terrified of having to turn our unit into a mini ICU and not having the ability to know how to do that, how to manage things that we aren't usually managing. So it becomes really important to give people the skills so that they have the ability. Figuring out what your barriers are will really help you move forward in projects. And so much of QI is this culture. This is looking at some suggestions for those 6 sources of influence. So based on what the barrier is in that grid, some ideas of how you might be able to motivate folks and overcome those barriers. So, if you're looking at things like social motivation, then this is really where you want peers as champions, as an example. Finally, what is identified as step 3 for Kotter's model of change, having a good implementation plan. So not just ending at this is my tool, this is my protocol, but really how do you take it beyond that level? So much of this is setting that important SMART goal. And then also, as Pat mentioned earlier, designing your plan around data. And I'm going to talk about that again in a second. So Amanda went through earlier, as you're selecting your project, how you determine where you're going to start. So often I see as folks have done a driver diagram or made this list of things they want to do, you go in order. That's not always the best way to do it. Things like prioritizing, looking at that impact feasibility, where are your low-hanging fruit, what is most important to make this project successful, those might be areas you want to explore first. So taking the tools to allow you to then say, all right, this is everything that we think we might need to do at this point, knowing it's going to adapt. What is most important to start with first? This was definitely a big thing in COVID, and I'm going to do an example in a second with a driver diagram. We talked a little bit about project management already. I think important things are planning out when you're going to begin your PCA cycles. Big mistakes that I even make within my team basis, don't space them out too much. Again, you're supposed to do small tests of change, come back, evaluate it, decide if it worked, move forward. In your implementation, this is where you really need to plan out, how do you educate folks and how do you make sure they are holding what you're trying to teach them. We had to think about this so differently during the last year. And then monitoring and reporting. What is the entity that you're going to share that data with, frequency, and what outcomes are you going to look at? And as you're making your plan, I'll give some examples. But I now look at, all right, what can we measure? If one of my main goals is improving communication, but you don't define how you're going to measure communication, you have no way to know if you've been effective with that or not. So your plan also needs to always connect to, if I'm doing this, how do we measure and make sure we're actually doing it? And did it have the outcome that we're intending to, which is obviously a huge component of health equity. And I'm going to give an example for that at the end. You've seen an iteration of this slide before with your SMART aim, anchoring your team and what the goal is and knowing that everyone is part of thinking that that SMART aim is the way we want to move forward. Starting your meetings with that aim will go a long way. COVID, this was a little harder, right? What is our aim? We had to evolve that a little bit, but I think at the end of the day, what most of us were trying to do was decreased exposures, improve treatment outcomes, and maintain some semblance of maternal, fetal, and family bonding in that process. And then we had to really refine it as we got more information and get it down to a SMART aim. Again, that project management piece is just as important. So more frequent contact points. So even if you do it every week for 30 minutes is better than if you don't do it until a month apart. So much of it for COVID, I don't know about your experiences, but I felt like we were having meetings every day. And that was critically important to adapt and improve and hear what was going on in other areas so that not everybody made the same mistake 20 times, but you got to hear it from one person once and then adapt and fix from that happening to you. And bringing those examples and those visual aids are really going to help. So bringing data, bringing patient stories, bringing something to thematically explain what you're working on. All right, I'm going to talk a little bit about protocols. There are folks that spend a lot of time on protocols, and then there are folks that spend not enough, and ideally somewhere in the middle is really important. So as much as possible, using evidence-based areas in your protocols, and it does not have to be perfect from the start. You will need to adapt it, and you will need to improve it, and you're going to find things that you thought made sense that don't later on. So it is never a perfect protocol. It's important to test it though before you go through whatever your process is to get it published, adapted, set in stone, because likely as you put it out in the real world, things will look really different. When we were trying to determine what our ideal process was going to be for shoulder dystocia in my hospital, we did a lot of simulation and we rewrote that order 1,000,000 times because, having your primary nurse doing 20 things at once, well, in real life, that, although they probably do 12 things at once, 20 is pushing it a bit much. So figuring out who does which step at which point, those real life experiences, and adapt it. So before you put it in a policy or protocol that becomes law in your hospital, make sure you've tested it out and then refined it via getting feedback in those PDSA cycles. Simulation is a major key and tool in that that will help you try it out before you're actually trying it out with a real patient. Some other things that folks have shared, having comment areas where people can write it in and share it with you later, having a box where they can drop tips and things that they want to make sure you share, and then having a forum to go through it and adapt it is going to go a long way. This is what I was referencing earlier and Pat talked about a little bit. So as you're designing your process, think about, can you measure that it's happening? In other words, if you want all of your patients to get a follow-up phone call after they've been diagnosed with COVID on day 24 or day 48, 48 hours, you need to make sure you have a way to measure if that's happening. So people need to know what the system is, you need to audit the system, and then you need to be able to show if it's working. Otherwise, you have no way of knowing until you get to the point of adverse events coming in. And the whole reason that we're setting up this infrastructure is so that you don't have to wait for something bad to happen. Qualitative data is equally as important, as Pat has said. For things like communication, this might mean observing communication with some sort of a structured framework to see if it's working. But if you have a goal, make sure you can measure it. And if you have a critical piece in your process, make sure you can measure it. Otherwise, you're not going to ever know if you're successful, and likely you're missing your major errors. And I do that in the phase before you go live. And okay, so let's use those first 3 steps as an example with COVID. So the first one was easy for us, right? Creating a sense of urgency. That happened. And I think everybody therefore was bought into this being something that we needed to figure out and adapt and make sure we could take care of our patients. So unlike most things, step 1 was a given for us. The next thing is creating your coalition. So who was on your team in whatever your healthcare setting was to figure out how you were going to adapt to COVID? And I'd love to see what you guys have in the chat to see who was in your team. This was one of the bigger teams in my hospital. And we kept kind of adding, realized how many different valuable contributions that there could be. So if you don't mind, and I just realized I can't see it, add in who you included in your hospital team for developing your COVID process. And I'm going to turn off my video because I heard I'm cutting out a little bit. Sorry about that, everybody. Okay, it looks like we've got DON, which I'm going to assume is Director of Nursing. Anybody else? Infection control, department directors, the health department, epidemiologists, absolutely. All of these were really critical. I'm going to show you a little bit about what I saw from some other folks, right? We're not used to as much having our QI teams have infection prevention. Certainly in a pandemic, we absolutely needed to. That meant we had to kind of figure out how to work with them well. There were a lot of transitions of care here, right? Inpatient and outpatient teams, system level teams, employee health, right? So much of this was workforce limitations when we all got sick. So this team was really pretty large to develop a good approach, and I'm seeing that in your answers. Okay, so here's the example of a driver diagram. Ours did not look like this. So much of this added on as we moved forward, but as you're looking at what is the best approach to move forward with reducing morbidity or improving outcomes. I know that there's a lot lacking in this as far as a smart aim, but I think this is kind of where a lot of us started with COVID. What were the different drivers, secondary drivers, and potential change ideas? So just as we talked about in prioritizing where you start, clearly we couldn't start with COVID testing, right? As the pandemic was starting out, so much of us did not have access to testing. So we really needed to start with these decreased exposure, patient education, determining how we were going to do management steps. And then as we developed more access to testing, this became a bigger portion of things. If you didn't have a plan for surge planning and you were in an area that had a really particularly high amount early on, you quickly realized this was one of those things that you needed to prioritize. So a little bit of an example of all of the different things that can go into a driver diagram and then how you need to prioritize them as you're starting. So my hospital did a lot with converting things to telemedicine to decreased exposures and to shift our inpatient, our nurses from outpatient to inpatient to be able to adapt. So as your team is sitting down and walking out those different portions of things, what are you going to measure to make sure you know you're doing the right things and don't need to adapt? So these were some of the things that I heard of folks focusing on within your labor and delivery population. What was your rate of positivity? How did that differ from the hospital general population? For a lot of us, it was a pretty big difference, either higher or lower. What did you see as far as illness severity, right? We didn't know at the beginning of the pandemic whether or not pregnant women and infants were going to have particularly high rates of morbidity and mortality. So following that was really important. What was your telemedicine plan? How often, who were you capturing for telemedicine? Who were you not? What is your readmission rates? And then some other important things like ICU admissions, readmissions, and delays in treatment. Okay, so going back to Cotter's model of change, communication and empowering action are two of the next important steps. In fact, if you had asked me years ago, I would have thought so much of this first 3 steps are the most critical ones. I now really think the communication and the embedding it in culture are 2 of the biggest challenges and the most important. And certainly for COVID, communication was a huge portion of this. So I'd love to hear some strategies of what folks did to communicate with your team members as you developed a plan for COVID. What were novel things that you did to make sure that got disseminated to everyone? I got to listen to this really great panel during the Society of Maternal Fetal Medicine of female OBGYN chairs of departments who largely had started in their leadership roles during the pandemic, and listening to them talk about what they thought was most critical in their leadership, all of it was communication. That redundancy of making sure everyone knew what was happening within your department, sharing of lessons, listening to problems that other folks might not have thought about, and also realizing that maybe what previously was important to our patients might look a little bit different, and same to our healthcare workers. And so actually listening to folks' input and adapting became important. So communication is 2-way. It's not just, this is what we're going to do, this is how we're going to test, but also hearing back, well, this patient made it all the way up from the emergency department with symptoms, and was actually really ill and exposed 20 different healthcare workers. Or this patient couldn't even get in because she was turned away as though she was a visitor and therefore ended up really sick somewhere else. So communication is completely 2-way. I saw folks talking about social media. Yeah, absolutely brilliant, especially with other medical resources within our community, communication during simulation and staff meetings with fellow women's health providers, right? That's that lessons learned across different areas. I did a lot more with participating in our intensive care unit communications and listening to what they were doing, as well as with internal medicine, which isn't something I had done before. All right, providing education. So as you develop your plan, you start communicating it. How do you really make sure people are receiving that information and it is giving them the knowledge you're intending to? So as you start this process, education also evolves as you get more specific and realize where the gaps are. So starting with, why are you doing what you're doing? So as you're talking about, say, COVID and simulations and exchanges between leaving a labor and delivery room and going to the OR and delivering a baby and getting it into the NICU or to the nursery, why are each of those steps so important, right? Each involve a different PPE exchange, a different point of vulnerability for our pregnant women and their infants. And these are the things that we're trying to make sure you know, and why it's so important that we have this standardized process, this new checklist, this new way we're doing this with donning and doffing and having people watch it. Even as I'm saying this, I'm realizing how much of that has become second nature, probably because of all of that education that we all did. But detailing the process, you're going to be more general when you start because you're going to learn what all the vulnerability points are and see what people don't know as you evolve. So giving that education, listening as you're giving it, adapting that process. Talk about in particular some important things to think about with adult learners. So as it goes on, including more and more simulation becomes really important, and adapting that feedback and framework. And then finally, by the end, you need to be extremely specific, right? If you give a very vague explanation of how you're, like if you just say, you're going to don and doff and move to the OR, that is not specific enough, right? Like you take this off, then put this on. This is the person watching you. These are the route that you go. You have to get really specific. Otherwise, there's going to be so much variability in the response. And then obviously dissemination and hitting as many people as possible. So training other people to be trainers, to keep going your education. And then finally, hardwiring tools behind it after you've educated folks to actually make it really hard for people to not follow that process. So for adult learners, and I also have learned this the hard way, we know a couple of things. Lecture-based training, which is why this is such a hard year, right? So much of what we're doing doesn't allow us to do those simulations face-to-face with large groups or our conferences where we're having really engaging discussions, but lecture-based training is going to be the least effective way. Learning by doing is going to be a lot more, and then practicing what you're doing and really refining those skills is going to be the most effective. I remember spending like a whole year really trying to focus on, this is when you activate massive transfusion protocol in our hospital. This is why. And I said it in all of these meetings and I sent it out in all of these emails. And still we would run into these people that said, I never heard that before. And I had started to feel like a broken record. And then I realized, you know what? It was just because I was doing it completely in the wrong way. I was picking the least effective ways to make sure everybody knew why we were doing that. And it's really including it in simulation, doing it in real life, bringing it up, doing the debrief. These are things that are going to make it a lot more effective. Okay, so I saw a lot of strategies for communication during COVID already, talking about simulations, rounding, face-to-face, handoffs, social media. These were some of the things that we did on our unit. I think it captured most of the things that you guys are talking about, but really that redundancy. I was going to say regionally, we did a pretty good job when I talked to other states. Many of you at the RAC and PCR level were interacting in some of the big cities between different hospitals. We did some sharing via AIM. There was a lot of collaboration even outside of our healthcare systems. So what are some things that, this is another question for you all in the chat. What are some things that you heard from team members as you created and implemented your COVID plans for infants or moms that made you adapt and change what you were doing? And I'm sure that there is a lot for that. I had a lot of really surprises. Yep, people talking about changing too much. Yeah, I can remember waking up every morning and checking the New England Journal and JAMA to see what had come out overnight, and then having those moments of, all right, do I change what we've done every single day? Is this enough to change what we do, or are we going to keep it going? Because otherwise it was constantly evolving. What's the rationale behind this, right? So much experience with that as well. My hospital went through a CMS review a number of years ago. I can tell you it was totally ineffective to tell people you need to stop wearing fake nails and no longer have nail polish in the OR, right? People are really motivated. That's one of the only, personal things that we have often in surgery. And all of a sudden you're telling them they can't do it and not why. Nobody's going to do it unless you explain the rationale why. And of course, not keeping up with the information. I heard a lot about, we can't put in all of our effort in the beginning, knowing that this was going to be a really long process. We're now in the ultra marathon. So thinking about how to slow down that change, focusing on wellness for all of us, because it was that. And then I saw that one of the fastest ways to burn us out was not putting adequate support on patient and families, meaning our healthcare team. One of the most defeating things was when we didn't do enough to support families and saw that impact on them. So a lot that you had to listen to and adapt. Uh-oh. Okay. Who here created a protocol for COVID? And how many got it exactly right on the first try? Right. That's like so real life, something that we're all so familiar with, right? You had to adapt it and adjust it. You had to decide how often you were going to do that. How many times have you adapted that protocol? Yeah, I saw Heather just said changed it today. I did the same thing. I just changed it today. Lost count. Yeah, I don't even know. Now we're just looking at updating by the date, no longer the version. Is it perfect yet? Absolutely not, right? We're going to keep adding information and adapting. What hydroxychloroquine went on the list quickly came off. Monoclonal antibodies went on, came off. Oh, maybe they're back on, right? We're adapting. We're trying to figure all of this out. So for your education plan, this is an example of the one from my hospital. It has changed so many times over. This is a really early one. And you figure it out, you adapt, you educate to it, you make sure folks know, and then you've got to slowly pull things off if they don't make sense anymore. So thinking about some of the crazy things that we did at the beginning of this, like separating moms and babies and trying to encourage people not to breastfeed, and then we had to really pivot and adapt all of that. That is so real life. We just did it in such a condensed period of time over the last year. So all critical things to remember as you're implementing your next project. I promise we're getting to the equity piece of this in just a second. Getting quick wins. How did you make sure folks knew your successes and celebrated them as opposed to focused on the exhausting part of always changing? So quick wins. What did you do well? Patient stories when they complimented and felt like it was a good experience despite all of this chaos. As you do your PDCA cycles and you found, folks did really well on certain process measures, or you had things that were really effective for taking care of patients, make sure you capture those, you share them, and you disseminate them, and you celebrate them. And that is so critically important to move things forward. This is an example from IHI of kind of going through that checklist of things that you need to look at as you're planning out your implementation. We're going to leave it there as a tool for you guys to come back to, but when a lot of this can seem abstract, sometimes getting it down to this level can really help. So as you're getting to the data reporting and monitoring, and we're going to start going through some of that and then figure out how we can take that and put that equity lens on it. How often are you looking at data? We talked about frequency. For all of us in Texas that have neonatal and maternal levels of care, what gets reported to your QAPI and when? What's that auditing plan? And then what does sustainability look like? That is an overwhelming abstract concept to most of us. If you're that way, you're not alone, but planning for that and including it as you're developing your projects is going to be really, really helpful. The things that are needed for sustainability are also needed for implementation. Okay, so I'm giving an example of a COVID dashboard and things that you might be collecting on your unit, reporting back to in your PDCA cycles, and things that might give you information. This is made up. Some of it is data from my hospital, but most of it is stuff that I added in here so that we can talk about it in a second and what you can do with it. So, are you tracking illness severity? How many of your women are ending up in the ICU? How many of your babies are ending up positive? What do those rates look like? What is your total population affected? What are your rates, right? This was our peak in July, and then folks are often coming back up. Sometimes you can catch that ahead of time and adapt and make different resources. And what worked really well and what did you do well? If you saw high rates of asymptomatic positive, you're going to adjust, some of your focus. Whereas if you're seeing really high rates of ICU illness, you need to figure out why it's so high in your patient population and then embedding it in your culture for sustainability. So these are slides that we already saw. For those of you who are part of AIM, we did it in the sustainability portion of postpartum hemorrhage. I'm using them again purely because I think they are worthwhile repeating. So when you get to the point of feeling like your project has been fully implemented, defining when you might transition into sustainability. Is that where you've met your goal for 3 consecutive months and now you think you can move into sustainability? You've met all of those different goals that you were moving forward, all your process measures, your outcome measures, and you feel like you're at this point. What does that mean? So this is how you keep that change consistent without becoming rigid. There are a couple of things that are critically important for sustainability. They're all things we just talked about, right? Having strong leadership, have a culture and infrastructure that's going to support improvement, having both multiple levels of involvement and accountability. And a lot of studies have focused that you have to have physician buy-in. You also have to have frontline staff buy-in and using data. Those are all things we've already talked about. And so how do you transition? You've got to figure out what are you going to keep measuring and what are you not? And how are you going to switch the workload so that you're not just adding on to the group that's been implementing, but how do you shift some to focus on sustainability and some to a new project, because you can't just keep adding on to what folks are doing. And I feel like I need to be telling that to myself, because I think that's a common problem we all make. These are some tools I'm going to go through really quickly, but they were referenced before. They're a toolkit for looking at how ready are you for sustainability and what do you need to focus on within your organization to make things more sustained. And I'm going to, just in the interest of time, move through them. All right, so all those things that we just talked about with COVID, now let's look at it from a health equity lens. So Christina showed earlier, this is the Council for Patient Safety Reduction of Racial and Ethnic Disparities bundle. And you could look at this and decide you're going to do each and every one of these steps and roll it out on your unit. I would actually, just as she mentioned, encourage you instead to incorporate that into every single project you do going forward, and looking at how you add it in. So this is an example of the hemorrhage bundle, what you could have included to account for bias and disparate outcomes in every step, right? So within readiness, just as Pat talked about in the data section, how do you make sure you have a system to collect patient level data, social determinants of health, race, ethnicity, and language? How are you making sure everyone in your team knows that this is an important issue and that you are working on improving your culture so that they have a health equity culture? In your response, have you developed things within this that minimize the ability to have bias? So standardization, having those tools right there so you don't have to wait for somebody to think and ask for them, removing those steps that can involve bias. And then everything you're looking at, your case review process, your data, all of those things, are you looking at the components that are leading to those inequitable outcomes? So stratifying by race, ethnicity, language, social determinants of health evaluations in your case review, and incorporating that into everything you do going forward. So as I talk about this with COVID and some examples, I'm going to make a couple of pretty big assumptions. A lot of this is so that we can talk about the implementation, but also because folks have covered it already. So number one, you already have a process in place that accurately assesses race, ethnicity, and language, and that you have a way to assess social determinants of health. You can disaggregate your data by race and ethnicity. So those were examples Pat already went through. And then you have a culture that's engaged. That is a big, big assumption. And I think probably where a lot of us have to spend a lot of our time. But to give you examples, we have to start with a couple of assumptions. So looking back at our plan, remember this very large, complicated driver diagram with things like telemedicine and simulation and universal testing and offering vaccination. There are a number of things in this that really left us vulnerable to increase racial and ethnic disparities. This was the data we're collecting, and I'm going to walk us back through it and show us what we can do with some data to look at ways to contribute more equitable care. Okay, so in this, anything in regards to illness severity that really is apparent to you all. So as you look at this, is there anything that seems not what would go in line with nationally reported things as far as illness severity? So if in this hospital, you've got 10% having severe and 10% having critical illness, that is way higher than the norm. Why would that be? So your hospital sits down to do a PDCA cycle or a PDSA cycle. And you want to look at your approach to providing care for patients with COVID-19. You specifically want to look at your outcomes and your illness severity and decide if there are things you need to do to improve in your process. So say your team says, all right, 20% with severe critical illness is way too high. We've got to figure out why. You guys make the goal of, we're going to reduce our ICU admissions by 50%. Is that a SMART goal? Yes. Do you have any idea how to do it from the data you just looked at? Absolutely not. So what are possible features in your plan that led to you having an increase in illness severity and might be directly related to racial and ethnic disparities? And if folks have an idea, go ahead and put it in the chat section. I'm going to move forward a little bit. Remember this that Christina already presented about using data stratification to improve health equity. So I'm going to give you a big clue there. If you are having a problem and you are focusing on an area, disaggregate your data, stratify it by race and ethnicity, and see if it's different in different populations. So if this hospital team did this, then let's see, they separated out by illness severity, by race and ethnicity. I'm going to give it to you in two different ways. The top is as a run chart. The bottom is as a table. And we've got right here, if you look, that blue line is illness severity in Black women, and they are a much higher portion of those with critical and severe illness compared to others. And you can see that down here, right? Whereas in non-Hispanic white women, and I did some data exaggeration, guys, so that this was really obvious, but I don't doubt that this exists. It's only 1% ending up in the ICU of non-Hispanic white women and 20% of Black women. So, right, if you hadn't focused on race and ethnicity, you would have totally have missed that. So what are areas in this driver diagram that probably are related to that? There are countless things. I'm gonna let you guys spend some time if you want to add it in on chat, but as an example, numerous of these steps within readiness, decreasing exposure and converting to telemedicine, right? We know there are lots of examples of how that really is utilized differently by different populations of people and is being offered differently and able to be utilized differently. We know that completely exists for vaccination and testing, as a lot of speakers have talked about throughout the day. So probably huge differences in this that are probably widening some of our outcome differences. So I'm going to talk about telemedicine. So say you decide to look specifically at the process measure of telemedicine, right? Who is using telemedicine? If you look at it in total, 40% are not, 60% are. That looks pretty darn good. What about if you disaggregate it and look at it stratified by race and ethnicity? You actually find here that you have a much lower uptake in both Black and Hispanic white pregnant women for telemedicine in this example than you do other populations. If we had been talking about ICU admission, looking at things like illness severity at the time of presentation, does this differ by different groups of people? And how can you promote education and a shared decision-making to those groups that might have changed when they're presenting, or other barriers? But I'm going to focus on telemedicine for the sake of our example. All right, so your team revises their SMART goal. They are going to reduce healthcare-related exposures to COVID by reducing telemedicine disparities between Black pregnant women and white pregnant women by 50% by June. So who needs to be on that team now? Different people than probably were on it before. Again, if your team has no idea, or even if they think they do, asking patients why they can't use telemedicine is going to go a very long way. You need to make sure that every point where a patient is interacting, you have somebody on your team that can talk about it. So much you hear that, that very frontline portion, if you hear from the person initiating telemedicine, this is what's happening, that's very different than if they get to the physician level. So who do you need to have in your team as you're looking at this? Some of the tools we talked about: process mapping, telemedicine, what currently happens in your system. So as an example in this one, there's a physician that evaluates the roster and decides purely based on medical condition who's appropriate for telemedicine or not, right? Do you have a medical condition that allows me to treat you via telemedicine, or is it really going to be best in person? So then that roster goes to a clinic charge nurse who reassigns the patients based on this criteria. The patients are notified by phone call, or if they've got something like MyChart or an EMR portal that allows them to get information, they're just notified they've been switched to telemedicine. And then on the day of the appointment, the nursing staff initiates the telemedicine. If they answer, they're connected to the physician and they do telemedicine. If they don't, they reschedule that visit again. If they don't, on the second rescheduling of that visit, they'll try to convert them to an in-person visit. All right, so you guys can probably think of a lot of areas why that process makes you very vulnerable to have huge differences in your outcomes, and you're not accounting for so many patient level barriers. Think of any, please send them in. But this team is going to sit down and then look at what are all the different areas that would make would make this vulnerable to have differences by different populations or different people with different barriers. So thinking about your strategy and how it can differ for people with different languages, right? Telemedicine is not going to work if you have a Spanish speaking patient and you've got only English speaking folks trying to make those connections. If they've got other social determinants of health barriers, like they don't have the video feature, they don't have the ability to do something virtually with continuous Wi-Fi, they have numerous other barriers, your strategy is totally not accounting for those. So you need to create a process that specifically thinks about those barriers, does something to address it and minimize it, and then engage in shared decision-making with the patients. Even if you think this is the best process for them, until you talk to them, you're not going to know. So we have to change the way we make some of these medical decisions. Instead of making it based on your medical complexity, actually engaging our patients in that process. And then measure and make sure what you think you're doing is actually working. So here's an example of how that could look a little different. So say you've got somebody who now looks and decides based on medical appropriateness. The first time that you are interacting with it, that should be in a conversation with your patient, not just a decision, all right, you've been moved to telemedicine. So explain the differences between an in-person visit and telemedicine, what the risks and benefits might be, individualize that to that person. If they want to proceed, assess what barriers they might have to that process, including social determinants of health, and then together make a decision whether that is the appropriate strategy to move forward. That other model probably just lost a lot of people to care and worsened those healthcare disparities. So then starting to think through, if you have a barrier, what is it and what are your strategies around it? If it's they don't have continuous access to internet and they don't have Wi-Fi and can stream and do video, can you convert them to a telephone call? Is that something they want? If incorporate translation services. So honestly starting to think about the things that will reduce the barriers that exist to get our patients that same access so that we have the same reduction in exposure. You know what, even if they don't have any barriers, for some people, telemedicine just might not be what they want. So again, continuing to ask them and do that shared decision making. These are all different ways of thinking of things we used to do. How do you communicate that out? I think this is why that why is critically important. Why are we changing this process? Why is it going to help our patients more? And exactly walking folks through it, as opposed to, right, that can look really overwhelming. Now you have to ask these 20 questions every time you do it, but this is why we're asking these 20 questions. And this is why it's so meaningful. So how you communicate this becomes really important, and also adding that within your copy. So it's not just a patient, a change that seems like a very big process, but there is a quality piece associated with it. I was going to pause and ask you to kind of design some things with education at this point and how that might be effective. But I think in the interest of being able to do a little bit in the Q&A, I'm going to move past it. I would say the final piece of this that I think is critically important in the example we did is to change your case review process and the data that you report to make sure you're continuously capturing this. So not just this type of chart that's looking at telemedicine, but actually looking at telemedicine broken down by race and ethnicity and language and other barriers, tracking that change over months so that you can more discreetly see if the change you're affecting is making the difference that you want to. And then modifying your case review process. So this is from a New England Journal of Medicine Innovations in Care Delivery article. And they look at these different components. So is there an inequitable care being given regarding access to care, transitions of care, quality of care, and then other socioeconomic impacts? So, you know, can you look at something in each one of these pieces in your case review process and determine where the barrier might have been, as opposed to what probably many of us are just doing and calling it a patient-related factor or a non-compliance? But, you know, what was the illness severity at access, and does that look different in different populations of our patients? You know, what happened in transitions of care where we might have lost huge portions, and are we adequately assessing social determinants of health and using them to help our patients by reducing barriers? So just one final tool, this severe maternal morbidity form that many of you have seen before from the Council of Patient Safety, the long form actually has a couple of social determinants of health related factors that I want to encourage everybody to think about looking in their presentation. Okay, and with that, I'm going to stop. I My chat has completely stopped and I can't tell if that is for reasons, but I'm going to stop and see if anybody has any kind of questions, and I'm going to turn it, I'm going to thank you all very much for being here today. And if we have any remaining Q&A, we can do it. And Christine, I realize I think we're communicating via the texting, but my phone has not been texting. So if we don't have any Q&A, do you mind just telling me?
Actually, I was just about to say that there's been a few questions that I've tried to type in answers to, but I think it would be really beneficial to hear you talk through it about how we've evaluated the social determinants of health for our patients during the COVID times. And some of the things that I typed in were our strategies in terms of assessing a patient's ability to have a telehealth visit, what visits are appropriate for telehealth versus in-person. Talked through how, we did offer telehealth, which is mostly telephone visits. Carrie and I, for those of you that don't know, we work at the same safety net hospital in Houston. And so there was a lot that we learned from our patients, thinking that we were providing this amazing option to not have to be in person, but realizing that there's a lot that we couldn't do from a standpoint of their phones didn't have video capabilities or picture capabilities. We were sending patients home with blood pressure cuffs and realizing that some of our patients didn't know how to read, so couldn't actually give us the values over the phone. So Carrie, I don't know if you want to add any more to that in terms of what your approach was in that scenario of using the social determinants of health to figure out what was the most appropriate for ambulatory and acute care.
Well, I think I revised this process probably by making every known mistake. One of the things that I think was most salient was a patient that was admitted very early on with COVID, no family there. And we didn't do a good job of really assessing what her barriers to care would be and what her concerns and her fears were in the communication piece. After that, I started in every single patient I was caring for. Early on, and I'm going to give an example of inpatient just because I think there's so much you can say about this. Really going through who lives in your house, what do they do, what do you do? If I tell you to go home and isolate, is that even possible for you? What does your home look like? Who do you sleep with? Things that I had never asked before. Do you have masks? Do we need to give you masks? Do you have the ability, if I tell you to go home and isolate, to like continue to feed yourself and your family? Are you the only one taking care of your kids? Like actually doing what is a real social history and understanding what's going on in our patients' lives, I think became really important in this. And then for follow-up, you just gave so many of the examples. I think we thought we were doing this wonderful thing by sending everyone home with blood pressure cuffs and telemedicine visits, and then slowly realizing all of the pieces that we needed to assess. So changing education to teaching them how to do it, having them do it and show it back, as opposed to just this is how you do it, but really like completing that loop. And each time we made a mistake, going back and refining it. One of the things that we have started doing now is actually a social determinants of health screening in a portion of our clinic that we're hoping now to do everywhere. And that is very enlightening. But yes, as you mentioned, for my patient population, at least in particular, that we take care of, video totally did not work at the time we did it. And so really converting to phone, or if that didn't work, still bringing them in as opposed to just assuming we could convert them. So again, I think that's that lesson learned, but really figuring out what is going on in their lives before you offer an intervention. And you tell them a recommendation from the CDC, is that going to work for them and why wouldn't, and how do you adopt that to a real world experience?
Thank you. And I see another question in the chat from Amelia Garcia, who's asking about, in order to determine data for neonatal outcomes, what is the standard process for documentation of ethnicity and race for infants, specifically when the infant is biracial? And I think that may even apply to adults. To be honest, as I'm learning that right now about our hospital, in terms of standardizing how you get the race and ethnicity data. And what it seems is that in our current EMR system, there is not an option for selecting multiracial or selecting more than one race and ethnicity. And so I don't know right now if that is possible, but we are talking about, or I don't know right now if your system may already have that built in, but if not, we are talking about building it in. So I don't know if any of the other speakers have any thoughts on that from a standpoint of how do you account for more than one race or ethnicity?
I'll add to that yeah, I know a lot of the EHR systems right now do not offer that as a capability. And that is one thing that we do encourage, is that you allow patients to select more than one race or ethnicity. And so that's probably something that needs to be taken up with your EHR team. As for the infants, I think it's the standard of care is to ask the mother to identify the neonate's race.
And I think all of the other questions have either been answered live or typed in. But as Amanda mentioned, we're happy to stay after a little bit longer to answer any additional questions live for those of you that may have any. I know some of our speakers may have to leave, but Amanda, I'll turn it back over to you to wrap us up.
Carrie, if you can advance to the next slide, or the next one after that. Yeah. Here is the link to the survey to complete in order to get your CE credits. That has been dropped in the chat box several times throughout the course of the afternoon, and it will also be emailed to you later this evening. But just a reminder, it has to be completed by February 17th in order to get credit, CE credits for attending this afternoon. And then Carrie, if you'll advance one more slide. And then my email address is here on the screen for you. If you have any questions about anything that we discussed today or anything that we didn't discuss today, please drop me an email. I'm happy to engage with you at any time. I'm also available to help perinatal units across the state of Texas to build their QI infrastructure, both, well, it used to be coming in person to the hospital. That's since been switched to virtually thanks to COVID, but eventually, hopefully I'll be able to go back to visiting on site to help with QI infrastructure. But in the meanwhile, feel free to email me with any questions. And we really want to thank you for attending today. Sorry, we went just a few minutes over, but we really appreciate all of your engagement this afternoon. We look forward to seeing you tomorrow and Friday for the main summit.
Thanks all.
Maliha, I am not very familiar with the raise your hand feature in Zoom, but I thought I saw something flash up that someone had raised their hand. Do you know how to find that?
Sorry, Dr. Davison, I missed. Can you say that again?
I said I'm not familiar with the raise your hand feature in Zoom, but I thought I saw something flash across the screen that said somebody's hand was raised. So I didn't know if you knew how to identify if somebody has a question.
So if you go to if you click on participants, and that would give you the option of you can see the raise hand question in there. That you show up the raise hand. Whoever raised the hand is raised, it will come up on the top on the participant list. Does it come up?
I don't actually see anything, so maybe they raised.
Nobody's hand is raised right now. I don't see.
Okay.
It. So we're good.
If anyone does have a question, then we are happy for you to just start talking. Are the Is the audience able to speak? I just want to make sure because I see that we still have over 100 participants on the call. I just want to make sure we haven't muted them all and they can't speak.
I think by default, they cannot speak. So if there's a question, they would have to type it in.
Okay. Okay, sorry about that, everyone. I didn't realize that mics were not enabled for the audience. So if you do have a question, we're still happy to answer them live if you want to type it in.
Amanda, so I just wanted to mention there was a question on the Q&A box about the race ethnicity part. I don't know if you're typing that answer or you can answer that question live. Sorry, you were on mute.
The question from Amelia Garcia.
Yes.
Yeah, we answered that question live at the very end.
Well, maybe we can just plan to stay on till it's 4:11. You want to say 4:15? Just since I see that there's still people on there, I just want to make sure we give them the opportunity to type in if that's what they're actively doing.
Absolutely.
If someone wants to talk, we can also try to allow them to talk. If you just chat in your name and I can try to find out, or if you can just raise your hand, then we can try to allow that option.
Hey guys, do you have a question in terms of if you need someone to speak? If you click on the attendees, you can go over their name and click on allow to talk, and that will let them turn their microphone on.
Thank you, John.
Guys, are you waiting on me?
No, we're just waiting until 4:15 just in case anybody's typing in any questions. And then we'll
Okay,
close
but
out.
do you understand if you want to promote someone?
Oh, yes. Yep, I see
Okay.
that.
Okay.
Okay, it doesn't look like there are any other questions at this time, so we'll go ahead and close the webinar. But if you do have questions and we're cutting out too early, please email me at awagner@utsystem.edu. And thank you so much for joining us today.